We are live in 1 minute.
Sorry?
Sir, we are live in 1 minute.
Okay. Hi, Kuldeep. Good morning.
Morning, sir.
Sir, namaskar.
Good morning, sir.
Morning, Dr. Srivastav. Good morning.
Morning, sir. Morning.
Morning, sir. Morning, sir.
Morning, Dr. Srivastav.
Nirmal has not joined. Maybe we can call.
Yeah, and I put some messages. Does anybody have his number? Nirmal?
I'll do that. I'll call.
Sure. Nirmal, Rangasai, and Jitesh. Three.
Srivastav, sir. Good morning.
J. Ranga Sai Gautam.
All of you. Hi.
Sir, we are live in 30 seconds, sir.
Okay.
Sir, we are live now.
Hi, good morning, everybody. I welcome you, all of you, for this first session on third day of ASSICON 2021. So we'll be starting the session. We have 9 speakers with us, and we have Dr. Sandeep Kesharwani and Dr. Sardeep Bhatt as moderators for this session. So we will directly go to this to the first speaker, Dr. Chintan Bhagchandani.
Good morning, everyone. My name is Dr. Chintan Bhagchandani. My topic is the prevalence of lumbosacral transitional vertebra and its effect on low back pain and radiculopathy. It's an whole spine MRI-based study. The prevalence of transitional vertebra has been reported by various literatures. Delport et al. He has used 3,000 LS spine radiographs and reported the prevalence of transitional vertebra as 30%. Shekarappa et al. In 2014, he has used 1,000 KUB radiographs and he has reported the prevalence of transitional vertebra is 8.1%. The relationship of transitional vertebra with low back pain has been proposed by Bertolotti, which has been in debate since decades. Nardo et al. He has used 4,636 KUB radiographs and given the prevalence of transitional vertebra is 18.1%. Tang et al. He has used 5,860 LS spine radiographs and he has reported the prevalence as 15.8%. Our aim of the study was to evaluate the prevalence of transitional vertebra and its association with low back pain and radiculopathy. Part 1 was to evaluate the prevalence of transitional vertebra. It was a retrospective study. Patients who are attending the emergency department with the spine fractures and were evaluated with whole spine MRI and lumbosacral AP radiographs were included in this study. Part 2 was association of LSTV with low back pain and radiculopathy. That was a prospective study, and patients who were seeking consent in spine outpatient department with low back pain and radiculopathy and underwent plain radiographs and whole spine MRI scan was included in this study. How do you identify a transitional vertebra on an MRI scan? We count down from the C2 caudally. We look at the change of the shape of the vertebral body to a squared appearance. In lumbarization, you will see there is a well-formed disc between S1 and S2, and there will be a well-formed facet joint. In sacralization, you will see there is a small L5-S1 disc. On MRI, we have seen lumbarization or sacralization. We have looked into Firman's grading. We have looked into total end plate scores and facet tropism. In plain lumbosacral radiographs, we have looked into Castelvis classification. So the prevalence of LSTV in part 1 was 11.6%, out of which sacralization was 18.9% and lumbarization was 18%. Castelvis type 2A was more common, followed by Castelvis type 3B. Part 2, in the patients with low back pain, the prevalence of transitional vertebra was found to be 14.9% and the sacralization was 12.3% and lumbarization was 2.6%. Firman's grading in patients with low back pain The degeneration at B level was statistically more significant in LSTV group compared to non-LSTV group. TEP score in patients with low back pain is more statistically significant in sacralization group compared to lumbarization group. Facet trophism in patients with low back pain is significant in sacralization group. In the patients with radiculopathy, the prevalence was found to be 17.4%, out of which sacralization was 14.2% and lumbarization was 3.2%. Firman's grading in radiculopathy patients, the degeneration was significant at B level in both lumbarization as well as sacralization group. TEP score in radiculopathy, the difference of TEP score was not statistically significant. While the facet trophism in patients with radiculopathy, difference is statistically significant in both the sacralization as well as lumbarization group. So we conclude that the prevalence of transitional vertebra was more common in females. In low back pain and radiculopathy, disc immediately scapholate to the transitional vertebra is more prone to degeneration than the transitional level, and the difference in TEP score and facet trophism was more statistically significant in sacralization group. Thank you.
Thank you, Dr. Chintan. We will, as discussed earlier, we will take the questions after 5 speakers have finished their talk. So, Sandeep and Sarvadeep, is it okay? So we'll go for the next speaker.
Yeah, yes, sir. Yes, sir.
So we can start with Dr. Kirtivasan P.
Good morning to all. Today I'm presenting a prospective observational study about the impact of acute lumbar disc herniation on sexual function in male patients. There is no conflict of interest to declare. Up to 72% of patients with lumbar disc herniation report varying degrees of disturbance in sexual activity, and it can be due to actual pain, physical restriction, depression, or adverse effects of medication. Sexual health of the individual has strong association with the mental, physical, and emotional status of the individual. The patient seeking surgical consultation rarely inquire about the effects of sexual activity, and the reasons being socio-cultural taboo and perceived stigma. Counseling about the sexual dysfunction by the treating surgeon is also deficient. The aim of the study is to determine the effects of lumbar disc herniation on sexual activity and to determine whether surgical intervention can improve any sexual dysfunction related to lumbar disc herniation. It is a prospective observational study done at the Ganga Hospital from November 2018 to April 2019. Male patients aged more than 18 with radiological evidence of lumbar disc herniation in MRI and who are willing to participate in the study were included. Pre-enrollment counseling was done in all the patients to emphasize confidentiality of identity and data, and the proper privacy was provided to all the patients. The clinical data collected includes demographics and the VAS score, Hospital Disability Index, and the psychological assessment was done through using Hospital Anxiety Depression Scale. A specific questionnaire for sexual function was done using BSFI score, which includes 5 components of sexual drive, erection, ejaculation, problem assessment, and overall satisfaction. Specific study questions were formed in the preoperative period as well as the 8 weeks post-operative period. Statistical analysis was done using SPSS software. Coming to the results, 22 patients were included in the study, and the mean age of the patients was 40. The VAS score, ODA, and BSFI score showed statistically significant improvement after the surgery. The Hospital Anxiety Depression Scale showed 15 patients in the depression range, whereas the 13 in anxiety. This chart shows improvement in individual components of BSFI after surgery. Coming to the sexual function questionnaire, after the development of lumbar disc herniation, 12 out of 22 patients reported decrease in frequency, whereas the 17 had decreased desire or satisfaction. Post-surgery, 15 had subjective improvement. Coming to correlation between various clinical parameters and BSFI, the duration of pain and the HAD score for depression had no bearing on the BSFI score, whereas the HAD scale for anxiety and ODA had a significant bearing on the BSFI score. Psychological factors play a vital role in sexual performance. In our study, more than 60% had anxiety and they had performed poorly in the BSFI scoring. Anxiety can be due to pain, fear about surgical intervention, or the misconception about the disease itself. However, there is no statistically significant difference between depression and sexual dysfunction. The BSFI score preoperatively was 27.86, which improved significantly after surgery. All patients had a good functional outcome shown by improvement in ODI. Of the 17 participants who mentioned decrease in desire or satisfaction, 15 had improvement after the surgery. When to resume sexual activity after surgery? Majority of participants, that is 13 out of 22, had resumed sexual activity within 6 weeks of surgery, and the rest of the participants cited fear of eliciting pain as a reason for delay. However, none had reported any increase in pain after first sexual intercourse after surgery. This highlights the importance of proper counseling to avoid unnecessary abstinence, as well as to prevent them from early return to sexual activity and increase their pain. The limitations of our study are a shorter follow-up period and smaller number of participants. To conclude, lumbar disc herniation resulted in sexual dysfunction in 77% of patients, and patients with a combination of axial and radicular pain were more affected. Anxiety rather than depression was more detrimental, and proper counseling regarding post-operative sexual activity is crucial for an overall better functional outcome. Thank you.
Thank you, Dr. Kritivasan. So, Sushil, can we play Dr. Swapnil Sanjay Hajare's paper, please?
Good morning, respected judges, my senior and my colleague. I'm presenting my research on interdiscal vacuum phenomena, radiological factor to predict the selective appearance, and a new morphological classification system. Interdiscal vacuum phenomena is defined as a well-defined dark area in the intervertebral disc place on plain radiograph at a single or multiple level, usually in the lumbar spine. Very less has been known about its pathophysiology, selective appearance, and the classification. With this background, we hypothesize that in sagittal plane, angular motion is more important than the translation motion for its appearance. Eccentric disc space narrowing and coronal transsubluxation are necessary for the vacuum phenomena appearance, and disruption of ALL and modic changes allows the gases to enter the disc cleft. So with this background, we aim to evaluate the radiological factors which are associated with the selective appearance of vacuum phenomena to understand the pathophysiology and to categorize vacuum phenomena for its classifications. We did a retrospective case control study on a patient with a back pain with or without lowering radicular pain, having a lumbosacral anterior posterior and the lateral stress view. We divided the patient into cases and control based on the presence or absence of vacuum phenomena. Vacuum phenomena were divided into 3 types: triangular rounded dot type, thread like a linear type, and dark white dense type. Dot type was further subdivided into anterior superior and anterior inferior type, and dense type was further subdivided into the anterior, middle, posterior, partial, and the pan type based on the relationship of wide with the inferior end plate. We added a modifier M for a multiple vacuum phenomena and S for the stable vacuum phenomena. AP X-ray was evaluated for the eccentric disc space narrowing, coronal listhesis, and lateral stress view. We calculated a sagittal angular motion difference, sagittal translation motion difference. MRI were evaluated for the Firman grading, modic change, ALR disruption, and vacuum phenomena signal intensity changes. So we had 1,049 patients with the prevalence of vacuum phenomena 28.4%. And we found that the cases had a significantly higher mean age compared to the control group. On a classification, dense was the most common type, followed by the linear and the dot type. On radiological parameters, cases had a more level with eccentric disc space narrowing, coronal listhesis. Cases had a more sagittal angular motion difference and a less sagittal translation motion difference. Cases had a more level with the ALR disruption, modic changes, and the more higher Firman grades. On MRI signal intensity changes, hyperintensity was the most common signal intensity change, and it was commonly found in T188 images. On group-based correlation, we found that patients with a disc degeneration commonly had a dot and linear type vacuum phenomena, whereas those with canal stenosis, listhesis, and disc prolapse had a dense type of vacuum phenomena. Also, the dense type vacuum phenomena had significantly more coronal subluxation, sagittal angular motion difference, sagittal translation motion difference, and ALR disruption compared to the dot and linear type. So our results support our hypothesis, as we found that patients with a vacuum phenomena had significantly more level with eccentric disc space narrowing, coronal subluxation, more sagittal angular motion difference, ALR disruption, and modic changes compared to the control group. Also, dense type had a more translation difference, including the more angular motion difference, which allows a greater amount of gas to be transported to the disc cleft. Even though the MRI does not have a superior diagnostic value to CT, we were able to identify 87% 0.8% vacuum phenomena on deviated image. So we want to conclude that irrespective of degenerative changes, critical radiological feature like eccentric displace narrowing, coronal listhesis, higher sagittal angular motion difference, higher sagittal translation motion difference, ALA disruption, higher Firman grades, modic changes are essential for the development of interdiscal vacuum phenomena. Patients with interdiscal vacuum phenomena need to be categorized for the documentation, referral, and evaluation. Our morphology-based classification will certainly help to do so. Thank you.
Thank you, Dr. Swapnil.
Thank you, sir.
It's a good paper. Can we move to Dr. Vishnu S?
Good morning. I'm going to talk about morphometric analysis of lumbar facet joint in a South Indian population, a cross-section study. Coming to the introduction, improper orientation of facet joints can alter the movements of lumbar spine, leading to spinal instability, facet joint osteoarthrosis, degenerative spondylodiscitis, disc prolapse, and non-specific back pain. The facet orientation is the angle of the facet joint in the transverse plane relative to its sagittal plane. Facet tropism is defined as the asymmetry of right and left vertebral facet joint angles, with one joint having a more sagittal orientation than the other. Coming to our materials and methods, very few studies have been done in Indian population to evaluate the facet joint orientation and then its incidence of facet tropism. Our study is a prospective study, a cross-sectional study, where computer tomographic scans analysis were done in 70 patients with spinal injuries. The orientation of the facet joint at the lumbar spine was measured using the method described by Noran et al. The injured facet joints were excluded from the study. Coming to the measurement of facet joint angle, the CT cut, which was taken at less than 2 degree obliquity of the lumbar spine in an injured patient, and the injured pedicles were excluded from the study. The sagittal line, mid-sagittal line, is drawn at the level of the mid-disc space, and the section of the facet angle where the facet joints are maximally seen is at the inferior end plate of the superior vertebra. Thus, the transverse plane line is formed by the point of the line joining the 2 points of the facet joint on the right side and the left side, and the angle is measured between the transverse plane and the sagittal plane on the right side and on the left side. The facet orientation at L1, L2, L2, L3, L3, L4, L4, L5, and L5S1 were calculated on both the right side and left side, and the incidence of facet tropism at each level was assessed. Coming to the results, the average facet orientation at L1, L2 was 27 degree, L2, L3 was 29 degree, L3, L4 was 30 degree, L4, L5 was 34 degree, L5S1 was 40 degrees. The prevalence of facet tropism, when the difference in the facet angle was more than 7 degrees, was 0.1% at L1, L2, 0.06% at L2, L3, 0.11% at L3, L4, 0.12% at L4, L5, 0.1% at L5S1. Coming to the conclusion, the incidence of facet tropism was most frequently seen at L4, L5 level and was least frequent at L2, L3 level. The facet orientation was similar in males and in females, and they become more coronally oriented in lower spinal segments. Further studies are needed to done to correlate the facet joint orientation and the incidence of facet tropism in South Indian population and the different causes of low backache and the early disc degenerative disease. These are my references, and thanking you.
Thank you, Dr. Vishnu, for your great presentation. So now can we have Dr. Kuldeep Bansal's presentation?
I'm presenting my paper, New Onset Sacroiliac Pain After Foraminal Interbody Fusion. What are the culprits? Introduction. We are considering this study because lower back pain following the surgery leads to unsatisfaction and the poor patient-related outcome and contribute to failed back syndrome. And the fusion surgery put stresses on the nearby surrounding structure such as SI joint, which maintains the cone of the balance. So that is also shown in the biomechanical studies too. Objective of this study is to know the incidence of the new onset sacroiliac pain following the TLIF fusion surgery and explore the association of it with the pelvic parameters. Methodology, we have included that we have done this study as a retrospective hospital record database study of the tertiary care center who underwent TLIF surgery from October 2018 to October 2019. Inclusion criteria is what the patient who had no previous documented SI joint involvement and whose data is with us within 6 months after the surgery and who underwent surgery, TLIF surgery for 4-5 and 5S1, primarily for degenerative disc disease. And exclusion criteria is what who has a documented SI joint involvement along with a syndromic like neurological deficit Koda-Equina syndrome were excluded from this study. Included patients were divided into two groups who has a SI joint pain and who doesn't have the SI joint pain. The patient who has a SI joint pain on clinical examination there is Patrick test positive as well as there is a direct tenderness of the SI joints. Patient who had a SI joint pain following the TLIF surgery has given intra-articular 1 cc of bupivacaine or along with 40 milligram of triamcinolone, and this test become diagnostic if there is significant pain relief more than 70% after 50 minutes of the injection, and this injection can be repeated after 1 week if the symptoms recur. We also included in the studies like demography of the patient, age, sex, VAS score of the back as well as the leg pain, along with the lumbar lordosis parameter like sacral tilt, pelvic incident, and pelvic incident, along with lumbar lordosis, along with apex of the lumbar lordosis. As we have included 354 patients, we started with a 467 patient after applying the exclusion criteria, and we had in final 354 patients. If we will see the chart, there is a significant migration of the apex in the SI joint group following the fusion surgery. If we will see in this chart, if we will see on this table, there is a significant migration, apex migration in the SI joint group, which is significant and contribute to the SI joint pain. The location of the lumbar apex post-operatively is changed in all the patients in group A who has a SI joint pain, and whereas 272 patients who underwent in group B has no change in the location of the lumbar apex post-operatively. This is the contributing factor for the SI joint symptom pain. Discussion: the incident in our study is 9.6 which is lower as compared to the other studies reported in the literature by Lee et al., Panica et al. We observed that the pre-operative lumbar lordosis is significantly lesser in the patient with new onset SI joint pain after the TLIF as compared to the normal control group. The change in the lumbar lordosis after the TLIF is not significantly associated with the new onset SI joint pain. Also, a capillary migration of the apex is found to be significantly associated with new onset SI joint pain. This is documented by Rosolis et al. Also in his study in different shapes of the lumbar lordosis. As is seen in the X-ray patient, there is a proximal migration of the apex of the lumbar lordosis. Limitation: there can be a false positive analgesic response also, and conclusion: the capillary migration of the lumbar lordosis is associated with new onset posterior SI joint pain with incidence of 9.6%. Thank you.
Thank you, Kuldeep. Now the papers are open for discussion. If anybody has any questions, can go ahead.
This is this question to Vishnu S. You have done this study on facet joint morphometry. Did you consider this lumbosacral transitional vertebra into consideration? Did you take that thing into your paper while your study was, when you're doing your study?
Dr. Vishnu?
Sir, we did only for this only we have done, sir. We didn't consider the lumbosacral transition, sir. Only for the lumbar facet joints alone we have considered. We have taken the measurements.
Okay. And another question is to this thing, Dr. Chintan. This lumbosacral transitional vertebra, it's very difficult to categorize unless you have whole spine MRI. So did you exclude all the patients who didn't have whole spine MRI, like a image which denoted, which started from the skull base and went till the sacrum in the part 1 study?
Yes, sir. Yes, sir. We have explored. We have already taken the patients who have undergone whole spine MRI with lumbosacral radiographs. Total, we had 7,000 patients. From it, I've already got. I just got 2,000 patients who had whole spine MRI with lumbosacral radiographs, sir, in part 1 of the study.
Okay.
It was a retrospective study, sir.
Can I ask a question?
Yes, Ankur.
Yeah, this question is to Dr. Swapnil. Swapnil, nice classification of the vacuum sign. I just wanted to ask, how does your classification translate into clinical application? So when I see in my OPD a vacuum sign, what do I start thinking? I mean, how does it apply to the clinics?
Thank you, sir. First of all, this like classification we propose helped for the communication better. So if we have patients with dense vacuum phenomena, they are like, we are doing the prospective study also now. So we found that they are having more back pain compared to the other vacuum phenomena, and they also have a more disc degeneration at that level and more modic changes. So for the further studies, it will be helpful. That classification will be helpful. So.
All right.
Now, Swapnil, just carry forward to Ankur's question. So this, what he said, this. So when you see that your band-like appearance or a dot-like appearance, does it translate into or does it change your decision in clinical practice, where to do just a decompression or a fusion?
Not exactly, sir. But for a dense type, it will certainly, not for linear type. Dense type, they found to have a more translational difference, like more instability. So in that aspect, it will help, sir.
So actually, that is where we need to come, because it is a radiological finding. So whether the vacuum sign really tells us that whether we need to change our way or the way to treat the patient, whether we need to go in for surgery or treat conservatively. So that is the thing what we need to see.
Yes.
And also, like when we are instrumenting, and let's say there is a vacuum phenomenon at L2, 3, and if we are having most prominent level at 3, 4, 4, 5, whether we should include that 2, 3 or not, that is also, it will be a better study if we find out if including or not including makes any changes.
Yeah.
If the dense type is there, so like pan type involvement or the partial type involvement, this segment has found to have more instability for sure. They had a more opening in the sagittal plane and also the more translation.
Sure, Swapnil.
Yeah, Swapnil, that is that your instability is seen radiologically, but is that radiological sign really translate into clinical picture? That is what we need to see. I think in your further study, you need to find out this.
Yes.
So that will be more helpful to us. So any other question?
I have one question for Kuldeep. Kuldeep, hi, I was really interested in your paper. So you had written in your exclusion criteria that we had excluded patients with any documented SI joint issue.
Yes, sir.
But what I have seen in my clinics, at least, that a lot of these patients who come with lumbar canal stenosis, with instabilities, with facet arthritis, the ones we are going to do in one level T-lip, a lot of them have actually a pre-existing SI joint pain. And, so did you specifically make sure that we were ruling these out? And if you did that, I would think a lot of people will get excluded from this study.
Yes, sir. So we have included that patients who have previous SI joint pain. We have taken only the patient with lumbar canal stenosis symptoms like claudication pain, sir. We have started the total 467 patients, sir, and the final sample size is just 354, sir.
So out of these 354 patients didn't have SI joint pain.
Sir, pre-operatively SI joint pain, sir.
They had SI joint pain pre-operatively.
They don't have, sir. They didn't have. They didn't have.
And they had instability.
Yes, sir. They have instability, sir. Well, they have instability, but they might not have that much back pain, but they have claudication pain mainly.
Because we are discussing fusion. So what I think is when we have done an interbody fusion, the patient must be having either very bad facets or instability for the fusion to be done. And if that is so, I would expect the patient to have an SI joint pain. and you have a huge number which doesn't have. So it's a little surprising to me.
Sir, we on clinical examination in the preoperative period, we see fiscal tenderness by doing the extension test or stock test. If the patient is having that, sir, we are more urged towards fixing the fusing the spine also. But patient typically in the preoperative period has no SI joint tenderness.
Okay.
So any other questions? So I have a questions to Dr. Kirti Vasan.
Yes, sir.
Hi, Kirti. Nice paper, and it is a really good thing to come out because it's a very common problem which people really don't discuss with us. So have you correlated in your paper the sexual dysfunction with other clinical parameters like radiculopathy, perianal numbness, or perianal sensation? So have you correlated with that?
Yes, sir. So actually,
the other symptoms, because why I'm asking is this: if you correlate, this is correlated with the other symptoms, and this can be an important clinical parameter also.
Yes, sir. So actually, we have excluded 2 patients who had cauda and perianal numbness from the study.
Okay. Okay.
And it is correlating well with the patients with more back pain rather than only radiculopathies.
Okay.
Patients who have more back pain tends to have more sexual dysfunction than patients with pure radiculopathy.
So patients who had more back pain, so did you operate with them, them with for lumbar disc herniation?
And back pain, patient had, there were 2 subsets of patients, patients with only radiculopathy and the patients with back pain and radiculopathy. So the patients who had more VAS scoring for back pain had a significant correlation in their sexual dysfunction.
So the back pain might be a problem because for the sexual dysfunction.
Yes.
You say. Yes. Okay.
Can I ask one question?
Sure, sir.
Yeah. This is to Dr. Kuldeep. Would you put in a summary of your paper, instead of telling that TLIF has led to this, whether this TLIF has actually made some changes in the SVA, SVA or, component of pelvic incidence?
Yes, sir.
So because that boils down to that only, I suppose. Is it?
Actually, in our center, sir, we don't get full standing X-ray after the fusion surgery, sir. We are getting the lumbosacral spine standing X-rays only. So that's why I haven't included the sagittal vertical axis in my study, sir.
Actually, it is the pre-operative X-ray which is important, because then you will know how much I have to open up the wedge. Okay?
Sir, in our center, sir, our protocol is, if the patient is posted for the fusion surgery, either TLIF, sir, we will get a standing lumbosacral spine X-ray, and if we suspect the instability of if the patient is having back pain more than the leg pain, sir, we then get a flexion extension X-ray rather than getting. If we are really suspecting a global imbalance and patient is stooping forward and having postural abnormality, then we get a whole spine X-ray, sir, in our center, sir.
Because practically the junction of the lumbar spine and the pelvis is the SI, is one of the important component is SI joint.
Yes, sir.
Right, sir. Right. Okay. Sir, can we move on to the next speaker, please? We are running short of time. We can again come back to the discussion after 4 speakers.
Yes.
Is it okay, sir?
Yeah, please.
So, Sushil, can we have Dr. Nitin Artsul's paper, please? No?
Hi, I'm Dr. Nitin Artsul from Sir Gangaram Hospital, New Delhi. The topic of my presentation is lumbar canal stenosis, a clinico-radiological analysis. The lumbar canal stenosis is characterized by narrowing of the spinal canal, compression of the dural sac, entrapment of the nerve roots, and a neurological claudication. This constriction pressure adversely affects the nerve function. Theoretically, more stenosis should lead to the more pressure and more neurological symptoms. Although the spinal canal narrowing is thought to be the defining feature for clinical diagnosis of the lumbar canal stenosis, the degree of the spinal canal stenosis necessary to elicit the neurological symptoms is not clear. Despite significant spinal canal narrowing, patients may have minute or no clinical symptoms. So the radiological changes were more extensive than expected from the clinical picture. and the degree of narrowing did not correspond to the degree of the clinical affection. Since the dural side cross-section area was not able to always accurately assess the clinical severity of the symptoms, other methods were proposed like qualitative grading or the morphological grading and the nerve root sedimentation sign. So the qualitative morphological grading for lumbar canal stenosis, it has been divided into A, B, C, D. So the A is again divided into the 4 types, A1, A2, A3, A4. And the B1 is the grainy appearance, and the grade C, there is some epidural fat, and the grade D is there is no epidural fat. The nerve sedimentation sign, as proposed by Barz et al., a positive sedimentation sign is defined as the absence of nerve root sedimentation in at least one transverse MRI image at a level above or below, disregarding the location of the site. Location of the scan within the level and its proximity to the maximum stenosis. So this is the negative sedimentation sign showing the normal MRI, and this is the positive sedimentation sign absent of nerve root sedimentation. So in our study, the aim was to find out the best radiological and the clinical criteria which can reliably predict the severity of the symptoms clinically in lumbar canal stenosis patients. So objective is to assess radiologically in each patient by these 3 radiological criteria and the clinical criteria, including the ODI and the self-reported walking time, and compare these clinical and the radiological criteria. So we assessed total 85 patients. They included patients with symptoms of neurological claudication, excluded the vascular and the neurological disorders. So the patient with symptom of neurological claudication were divided into 2 groups. The patient who could walk less than 30 minutes and patient who could walk more than 30 minutes, and the statistical analysis was done. So this is the analysis for the ODI, this is the analysis for DSCA. The main difference between the back pain and the neurological clotting, but not statistically significant correlation. The DSA and the morphological grading correlation was statistically significant in both less than 30 minutes and more than 30 minutes walking group. The ODI correlation to DSCA, morphological grading and the sedimentation sign was statistically not significant. The sedimentation sign correlation to morphological grading and the DSCA was statistically not significant. So to conclude, the morphological grading could be a better radiological indicator for assessing the severity of the lumbar canal stenosis and sedimentation sign. We cannot reliably assess the severity of the clinical symptoms using the radiological parameters only. Maybe ODI is not a very good indicator for clinical severity of the symptoms in lumbar canal stenosis. Thank you.
Thank you, Dr. Nitin, for your lovely presentation. So now we go to Dr. Nirmal Patil. Can we have his presentation?
Hello, good morning. Today I'm going to speak about thoracoscope assisted anterior interbody fusion and simultaneous posterior instrumentation in prone position. A desirable approach would be the one that can combine the advantages of the anterior approach and the posterior approach in a single stage and single position. We believe anterior thoracoscope assisted anterior interbody fusion surgery is the answer to this question. But one question does arise: does MIS procedures have good fusion rate? With this, the aim of the study was to analyze the fusion rate and progression of fusion in interbody fusion surgeries performed thoracoscopically and to assess diagnosis-dependent fusion process. A single or double lumen lung ventilation is performed. These are the standard equipment for thoracoscopy. Patient is positioned in prone position, and this is the setup of the operative team. A working portal is then taken in the mid-axillary line, following which a camera portal is taken in the posterior axillary line in the same rib space as the targeted level. A finger dissection is performed. A retractor through the working portal is inserted to retract the lungs. Then the pleura is opened. A disc space is identified. Discectomy is done. And end plate preparation is done, and canal is decompressed. Subsequently, in the same position, a open midline approach and release is performed, or only MIS pedicle screw insertions can be done. Then using simultaneous posterior compression and anterior distraction, one can correct the deformity. A rod is applied and the position is then secured. Then after measuring the anterior defect, anterior cage reconstruction is done. With this technique, we have analyzed a total of 313 levels with a mean follow-up of 2000 days. Fractures considered 96 cases, degenerative condition 105 cases, spondylitis 74 cases. Only interbody fusion surgeries were included. This is the classification system that we used. Patients were graded between grade 0 to grade 4. This was recently accepted in Global Spine Journal. As you can see in this image, patient was sequentially x-rayed and there is a progression of fusion from grade 4 to grade 0 at this final follow-up 133 months. Similarly, in this patient, a final follow-up of 175 months, grade 0 is reached. In this patient as well, at 132 months, bony remodeling and grade 0 fusion is reached. So in all, in our study, the fusion rate was 88.81%, with the highest fusion rate in pyogenic spondylitis of 90.5% and the lowest one in ankylosing spondylitis. Mid-thoracic spine had a higher fusion rate, whereas thoracolumbar spine had lower fusion rate. Older age group also had lower fusion rate of 79.24%. Diagnosis as such did not have any effect on the fusion process, but age as well as operative level did have a significant impact on the fusion rate. As you can see in the operative time, the total operative time was 222 minutes, whereas the average thoracoscopy time was 92.68 minutes and the average posterior time was 134 minutes. The operative time was higher in degenerative groups, especially in the thoracic disc cases, which is expected as this involves opening of the posterior longitudinal ligament and decompression of the thecal sac. When on analyzing individual levels as such did not have any significant impact on the operative time. Thus, in the conclusion, I can say that thoracoscope-assisted procedures have good long-term fusion rates and comparable operative time to posterior-based techniques. Thank you.
Thank you, Dr. Nirmal. So we can straight away go to Dr. Jay Ranga Sai Gautam, please.
Good morning, sir. A natural history of patients with cervical radiculopathy treated conservatively and correlating with the clinical and MRI features after a mean follow-up of 33 months. The clinical response of cervical disc herniation with radiculopathy when treated conservatively is believed to be favorable. Few published studies are focused solely on the clinical outcome after conservative management. Some study, a selection of study population was not homogeneous, and in some study, variety of treatment options like the root blocks, oral epidural steroids are also included under conservative management. The radiological behavior of the herniated cervical disc over time is poorly known. Study focusing on this aspect are scarce. The present study attempts to evaluate the clinical and radiological natural history in such patients. Aim is to determine the natural history of patients with cervical radiculopathy treated conservatively and correlating the clinical and MRI features after a mean follow-up of 33 months. A total of 46 patients with a mean age of 42.9 years and a mean follow-up of 33 months with cervical radiculopathy due to single-level disc herniation with dermatomal and myotomal distribution of symptoms between January 2012 and December 2018 were enrolled in the study. All patients managed with canal 6, trigobalin, along with physical therapy in the form of TENS. And both index and follow-up used functional assessment tool used was neck disability index, visual analog scale scoring when used was to assess the severity of the neck pain and arm pain, and patient-specific functional scale was used to measure the satisfactory level of the patient or follow-up visit. Radiological evaluation of disc degeneration using mean score and neural foraminal stenosis using Kim score. Volume of the protected disc was measured by assuming it to be an asymmetrical hemicylinder. Where student retest was used to compare the index and follow-up NDS scores and VAS scores. The grade of the disc material was assessed by utilizing decrease in the neural foraminal stenosis grade and decrease in the calculated disc volume. Correlation between clinical and radiological parameters is done using Pearson coefficient. The number of patients at various level of the disc in our study. In most of the population, most of the patients in our study group fall between 41 to 50 years of age. The NDA score, VAS score of the arm and neck score show significant decrease when compared with the initial visit at final follow-up. Other parameters like the paresthesias, motor weakness, sensory deficits, and neck range of motion restriction for the clinical parameters assessed. Clinical course, 52 patients showed lasting pain relief, and 37 patients showed minor recurrent episodes, and 11% of the patients showed major recurrent episodes. And these 11% of the patients were advised with surgical management at 1 year follow-up. Radiological parameters studied the neural foraminal stenosis score, the Mazak score, calculated disc prolapse at both index and final follow-up. 76% of the patients showed decrease in the actual size of the disc, and 15% of the patients showed no change in the size of the disc. 9% of the patients showed increase in size of the disc. Patients with less than 50% resolution of the protected disc and less than 50% improvement in the NDS score at final follow-up took significantly longer time for the initial relief of symptoms. We did not find any correlation between the improvement of NDS score and improvement of the neural foraminal stenosis and decrease in the disc volume. What happens to the radiological findings of the clinical findings subset? We observed that a decrease in the mean of 1.53 to 1.1, which is statistically significant in neural foraminal stenosis grade for the involved side. And with neural foraminal stenosis grading, only 17 out of 46 patients showed reduction, but the remaining others retained the original grade. We calculated the actual volume of the protected disc, which shows statistically significant improvement at final follow-up. The measurement for disc volume, small study population of the major limitation of our study, the actual protected disc is irregular, and calculation of the exact volume of the protected disc is very difficult. Our study did not find statistical significant changes in the disc degeneration. This may be due to shorter duration of the follow-up. Some of the examples: excellent clinical outcome with near complete resorption of the disc at 1 year follow-up, excellent clinical outcome with no resorption of the disc at 1 year follow-up, and average clinical outcome with near complete resorption of the disc. Clinical improvement was seen in 89% of the study group, and MRI showed statistical significant reduction of the protected disc volume in 76% of the study group. However, correlation between the two could not be proved. Observation regarding the disc degeneration was inconclusive with poor inter-observer reliability. And these are my references. Thank you.
Thank you, Dr. Jay Ranga. So we move to the final speaker, Dr. Jitesh Mangwani.
Good morning to the judges, the moderators, and my co-presenters. The topic of my study is comparison of clinical outcomes of unguided versus ultrasound-guided sacroiliac joint infiltration and SI dysfunction-related back pain, a randomized control study. Ultrasound-guided and fluoroscopy-guided injection are the standard injection techniques in SI joint infiltration. However, these procedures are limited primarily owing to the limited availability and the cost factor. Also, fluoroscopy-guided procedures have an added disadvantage of effects of radiation. A cheaper, readily available alternative is unguided injection. However, there is no quality evidence supporting its use and comparing it with other injection techniques. The literature primarily talks about the effects of fluoroscopy-guided injections, and also the cadaveric studies talking about the effects of ultrasound-guided injections. There is very few literature that talks about the unguided sacroiliac injection techniques. Our aim was to assess the efficacy of unguided sacroiliac infiltration techniques in comparison to ultrasound injection guided techniques. The research question was, does unguided sacroiliac joint infiltration gives comparative results to that of ultrasound guided injections? Our hypothesis was that both these injection techniques will give equal and good results. The study was done in Indian Spinal Injury Center over a 6-month duration period. The sample size was calculated using master V2 software technique, assuming a 5% significance and 80% power. The required sample size was 33 in each group. However, 37 was taken, taking around 10% dropout rates. Mechanical low back pain without dermatomal pain, tenderness over SI joint, 14 finger test positive, and positive results out of 3 in 5, that is distraction, thigh thrust, Faber, compression, gaseous strength, negative chem stress, and SLRT were included in the study. Patients inflammatory back pain, spinal infection, local infection at injection site, and hepatosis were excluded. A cocktail of fast-acting, short half-life, slow-acting, longer half-life, and steroid was used in all the cases after drug sensitivity. Under all aseptic precautions, the infiltration was given in the ultrasound room either by manual unguided palpation of the joint or ultrasound-guided technique. The study design is a blinded technique. That is, the schedule was generated beforehand using SPSS software. The schedule was in envelopes and sealed. After the preparation of the patient, envelope was opened to confirm which injection will be given to which patient. VAS scores and ODI was calculated after the selection of the patients. Ultrasound-guided injection or unguided injections were given. The VAS score and ODI were calculated immediately after the injection and 2, 6, and 12 weeks period. The results were such that the sex distribution was not significantly different in the two categories as seen here. Comorbidity-wise, the patients did not differ statistically as per the single or multiple comorbidities. The VAS score in the two categories, that is the ultrasound-guided and unguided techniques, over the period of presentation, post-procedure, and follow-up at 2, 6, and 12 weeks did not differ statistically. This is the trend of VAS score. The provocative VAS scores that is done after the Faber test at presentation post-procedure was borderline significant in two categories with better results in unguided injection techniques. These are the provocative VAS scores. The Japanese Orthopaedic Association low back scores was statistically significant p-value of 0.004 with better results in unguided injection techniques as compared to ultrasound guided injection techniques over follow-up period of 2, 6, and 12 weeks. These are the trends of JOA scores. The Oswestry Low Back Pain Disability Index was statistically not significant in the two categories on presentation and follow-up on 2, 6, and 12 weeks. The need for repeat injections was not statistically different in the two categories with a p-value of 0.741. There is no statistical significance vis-a-vis comorbidities of the patients. The VAS score in the two categories did not differ statistically. There was significant difference in the values of provocative works, but it was borderline. JOA scores are found statistically better in patients with unguided techniques. ODI scores in both the modalities did not differ statistically. The need of repeat injection is same in both the categories. Cost and availability of ultrasound guided injections are definitely a concern. Hence, possibly the unguided techniques are better. There is no added advantage of ultrasound guided injections over unguided techniques. Unguided techniques are as good as ultrasound guided infiltrations. A larger population with comparison possibly with radiologically guided techniques, that is fluoroscopy, may be recommended. Thank you.
Thank you, Jitesh, for your lovely presentation. So now the house is open for discussion.
Can I ask one question to Dr. Nirmal Patil?
Sure, sir. Please go ahead.
Yeah.
Nirmal?
Dr. Nirmal, you have to unmute. Dr. Nirmal, you have to unmute.
Hello, sir.
Yeah, good presentation, good thought process. Only my one concern is that in higher thoracic level, you have done in D3, D5 also, I suppose.
Yeah.
And you are choosing the entry point from the mid-axillary line.
Yeah.
Okay. So one thing that, you might be having some side selection, right side or left side, that is one. And second, does scapula come in your way of doing all these procedures?
Yeah, a scapula does come in the way. So in that case, we usually position the arm in such a way that the scapula is positioned medially, and then we take a lower entry point in these cases. And usually for the higher thoracic level, we prefer a left-sided entry for the thoracic side as compared to the right side.
Because usually a normal thoracotomy, because the arch of aorta comes there. So that was the concern I asked this question. So, but still you take from the left side.
Yeah.
Okay. Thank you.
Yes, Ayush.
Yeah. So, Nirmal, nice paper. We do have our own experience single position surgeries. Okay. There are few caveats to doing single position surgery, especially when you're doing a multi-level construct. And you, especially if you're if there is a instability anteriorly, then one need to be very, very careful. Sometimes we even have to put the screws first. Then, what did you find when doing a multi-level single position MIS fixation could be very, very challenging. How do you manage that? Because we have some experience, and sometimes the rod contouring everything could be very, very tricky in these cases.
So the selection, as you can see in this technique, both open as well as MIS can be done simultaneously. If there is no need of much of deformity correction, we go ahead with the MIS technique. But if we need a lot of rod contouring and releases, like Ponti's osteotomy, then we first do a open posterior approach, make the releases, and then do a discectomy, put a temporary rod on one side, and then simultaneously correct the apply a force from behind and distract anteriorly, and then fix the column. So that way, the problem of the graft coming out when repositioning, especially from prone to a lateral position and all that thing is avoided.
Yeah. So one of the things we have find is you can do. We have done simultaneous posterior and anterior. So like if you have to release, like one surgeon can do from posterior, and the same like my assistant can fix from and like anterior and posterior together. Do you any experience with that? two team doing anterior and posterior. That really saves some time. We have some, and we found that quite useful.
So that is usually for the lumbar spine you're talking about, right?
Yeah,
but in the thoracic spine, and the position of this patient will be lateral position. So if the patient is prone, because of the gravity, the correction is much more, we feel the force that we can apply while correcting the deformity is also much more from behind. So that's why, especially for thoracic spine, I think this is good. But for lumbar spine, obviously, lateral position is a good option.
Okay. Thank you.
This unguided injection, this is question to Dr. Jitesh. It is completely based on anatomical landmarks and by palpation technique?
Yes, sir.
So Jitesh, what were your complications when you gave unguided injections?
So complications per se, we just incurred in one of the patients. One patient, which again we are reporting as a case study, after giving unguided injection, one patient developed monoplegia on the right side, which may be an untoward effect of the drug. Apart from this patient, sir, as such, we didn't incur any other complications.
So how do you ensure? That means that any injections, whenever we give any, suppose we plan for a facet injection or a nerve root injection, so you can give it in the OPD as such without, were you doing these injections? So you didn't do with under the C-arm?
No, sir. So that is what I listed in the limitations. That is what I listed in the limitation. A comparison with a fluoroscopy guided C-arm technique should be done.
So that's okay. So what was the effect? So when you do this blinded procedure, was the effect of your procedure same as those being done under some guidance?
Yes, sir.
So then you recommend all these procedures to be done in a blind way?
Yes, sir. In an unguided way.
So only SI joint or other joints also?
So only SI joint, sir. Only SI joint, sir.
This is the question to Dr. Nitin. Does your paper gives any extra information what we know beforehand with respect to lumbar canal stenosis and radiology?
Actually, we wanted to find out which radiological criteria is better and whether there is any correlation. So we did this OPD-based study, but there is no correlation between the patient's presentation and the radiological finding. The patient can present with stenosis with walking distance more than 30 minutes. That we wanted to prove, and which radiological criteria. So the morphological grading is better compared to the sedimentation at dural sac cross-section area.
Nitin, can I add one question also? So there are certain situations in your clinical practice when you see a patient coming to you and complains of claudication. But on MRI, you don't see any finding, any significant finding correlating to the clinical picture. So what more you can do in these scenario to say that the patient classically says that he walks, he gets a pain, radicular pain on a particular dermatome on walking. But on a MRI, there is no significant compression or finding.
Yeah, so there are basically two things. The first, there may be some dynamic issues. So maybe the dynamic MRIs, which we have not included in our study. So that might help if the patient is having symptoms and that is not correlating with the MRI. But that we have not included.
So do you do weight bearing MRI in your practice?
No. We just do the simple MRI.
Because when we do an MRI, the MRI is done in a prone position or a supine position. So as such, the patient doesn't give any symptoms on lying down or sitting. So do you think that a dynamic MRI or a weight-bearing MRI will be a more useful radiological criteria?
That should be done in patient with no radiological finding in the supine MRI. Then just to find out the pathology, we can do these dynamic MRIs. That might help.
Great. So any other questions from the panelists?
Yeah, I've got a question for, sorry, was there somebody else with the question?
No. You can go ahead, Thomas, please.
Sorry, I had a question for the speaker who spoke about lumbar canal stenosis.
Yeah, Nitin.
Yeah. So you said there was some difficulty in measuring the dural cross-sectional area. What was the difficulty?
So basically
on the MRI.
So there are no softwares available. So we use the SurgiMap. Yeah.
So it's a very easy process actually. I mean, it's digital. You just have to outline the surface of the dura, and the most PAC systems or MRI systems will allow you to measure the cross-sectional area if you just outline the area of the dura. Anyway, that's fine. Thank you. Thank you.
I think most of the MRI machines also have that software, Thomas.
Yes.
Nowadays, few of the MRI reports, they mention in the dural section, the cross-section area. But our difficulty was mainly when there was no epidural fat. So it was completely black with severe stenosis. Maybe of morphological grading.
Okay. Thank you, Thomas. I think we are reaching the time. It's around 9 o'clock. So I thank all the speakers for their excellent talk and all the panelists, moderators, Ayush, Thomas. So thank you all for making it a lovely session and good discussion. So I think we move to the next session.
Yes.
We have 5 minutes before the next session.
Yes. So I'd like to thank the moderators and speakers of this session for that for the excellent papers and the interactive session. Thank you, moderators, Dr. Bibu Mohapatra, Dr. Sarvadeep Dutt, and Dr. Sandeep Kesavani. Thank you. And big thanks to all the speakers for your excellent presentations. And thank you very much for keeping to time. So we've perfectly on time. So it's 9 o'clock now. We've got another couple of minutes before we start off the next session, which is improving outcomes in spine surgery. The moderators for this session are Dr. Ketan Badani, Dr. Abhishek Srivastava, and Dr. Sahil Majid. I think I see all three of them logged in. Welcome, gentlemen. And I'd like, if you can take over from now. The speakers for the next session have all logged in too.
Good morning, everyone. Shall we start the next session or we wait for a few minutes?
I think we'll wait for a few minutes. It starts exactly at 9:05. Yes.
Yeah, I think we can wait for a couple of minutes more.
Time for a quick cup of coffee.
Yeah.
Good morning. Yeah.
So everyone wakes up.
Yeah. It was a good interactive session. So yeah.
Hi Abhishek, how are you?
I'm all right. How are you?
Good
morning.
Good morning and congratulations also.
Thank you. It was a tough call, close call.
Close call. Great.
Can I request the moderators? We can probably start off with the introduction of the speakers for the next session. We've got an international panel.
Yeah,
and I think it'd be worthwhile, and we got a very prominent speakers. So if you can just introduce the panel, the speakers, I think.
So as the topic of the session is the outcomes of surgery. Of course, outcome is the final word. Everybody is interested in good outcomes. Whatever it takes to get a good outcome is important, because that leads to a good satisfaction for the surgeon, a happy patient, and happy ending. So in this regard, we have amongst us Dr. Sigurd Berwin, who is a spine surgeon in San Francisco at the UCSF, and apart from his basic work as spine surgeon, he has some special interest in measuring the outcomes of spine surgeries, and he has studied multiple variables affecting different types of surgeries of the spine, specifically in the scoliosis group, and he has had several publications in this subject. So he would be a very good person to tell us how we can improve the outcomes of spine surgery. What are the factors that will affect the outcomes? And I welcome Dr. Sigurd Berwan to our meeting, and thank him for being here to present his thoughts on the matter. So I think it is just about 2 more minutes to start.
Yeah. One thing more, I was also just going through Dr. Berwan's, CV, and he has also studied politics and economics at Oxford, which is quite different from, medicine, what we normally, we are on a single track, but he has got quite a range of topics which he has studied when he was, in his formative years.
Yeah,
I think that has led to, more of, towards this topic that he has gone and, looked into the human aspect of the things.
Yeah, right. Multifaceted personality.
Thank you both for that very, very
generous. Hello, can you hear me, Dr. Gautam Zaveri?
Yes, Gautam.
Okay. Sushil, can you play the presentation, please?
Okay, sir.
Hello.
Gautam, we can hear you.
Yeah, please start. What are we waiting for?
Sushil, please start the presentation.
Okay. Good morning, and thank you to everybody. I really appreciate the opportunity to contribute to the Congress, and that's terrific. If you want to control the slides, otherwise I can share my own screen, whichever you prefer. But if you control it, I'll advance. So this symposium is going to be on improving outcomes in spine surgery, and I appreciate the moderators and the course organizers for allowing the opportunity to contribute to the program. If we can go ahead to the next slide, I'm going to focus on complex spinal disorders. I think it's important to recognize that complex disorders are an important priority for our healthcare systems, really internationally. And I'll talk a bit about why complex spinal disorders are important in the range of disorders that involve the spine that we consider complex. Surgical management of complex spinal disorders really has a significant potential for both risk as well as benefit. And appropriate care, I think, is important to define, where appropriate care is when we expect the benefits to exceed by a wide margin the risks. And knowledge of the expected benefits and expected risks is really fundamental to empowering informed choice for both physicians, surgeons, and patients, most importantly. So I think that the optimal management for complex spinal disorders really requires systematic protocols that involve preoperative optimization, some intraoperative standardization, as well as postoperative accountability. So for every phase of care, we've got opportunities to optimize our pathways. The next slide, please. Complex spinal disorders in general, the definition that I've given in prior publications include disorders of the spine, be it pediatric or adult, that involve symptomatic neural compression or that involve some degree of malalignment, especially malalignment that's likely to be progressive without surgical intervention. And some of the examples I might give include early onset scoliosis, adult and pediatric deformity of the spine, cervical and thoracic myelopathy, tumors of the spine. I added to this infection and other conditions of the spine in the most recent version. But let's go to the next slide, please. And this just demonstrates some examples of complex disorders as neuromuscular curves, infectious disorders, tumors, and significant deformity of the adult and pediatric spine. Next slide, please. So when we think about priorities for our healthcare systems, again, internationally, our health system priorities really are defined by the prevalence of the disorder and really how much of the population the disorder impacts. How much of our healthcare system requires utilization for care for the disorder, It gets into the economic costs and the impact of disorders. So the impact of the disorder regarding disability and the impact on health-related quality of life. Next slide, please. And when we think about the impact of spinal disorders and health-related quality of life, many of you are familiar with the global burden of disease studies, looking at over 220 common conditions and the impact on these conditions on quality of life. Next slide, please. So this was an international study that involved over 40,000 people, looking at impact of a variety of different disorders. I think most of you are familiar, next slide, please, that disorders of the lumbar and cervical spine were really among the most impactful disorders across the world. Next slide, please. And some of the work done by the European Spine Study Group and Ferran Pellicer being the lead on this, looking at adult deformity specifically and the impact of adult deformity and health-related quality of life, comparing this to other common conditions, including diabetes, chronic lung disease, congestive heart failure, arthritis, and demonstrating quite clearly that deformity and complex deformity in the adult spine really has a larger impact in every domain of health-related quality of life across the SF-36 scales. Next slide, please. So clearly, we as a community of physicians who care for disorders of the spine are caring for a disorder that's a priority for our healthcare systems internationally. So let's talk a bit more about then management and specific strategies for how we manage complex disorders. I think it's important to recognize the variability in how we may approach common problems. And certainly the role for non-operative care, rehabilitation, injection, medications, bracing, neuromodulation. Variability in strategies and dramatic differences in the invasiveness of different options. The role of circumferential fusion has been spoken to quite a bit. The role of biologics in spine surgery, minimally invasive versus open approaches, and navigation and robotics. I spent some time in the vendor area, in the exhibit area, and some very nice demonstrations by some of the sponsors of some new robotic techniques. Next slide, please. And again, management of complex disorders of the spine is really characterized by significant variability. There's a lot of variability in the clinical presentation of patients and a lot of variability in clinical strategies. And this variability isn't a nation to nation, and in many areas it's region to region or even hospital to hospital. And so across the world internationally, we see the opportunity for significant variation. We also see, I think, through conferences like this, the creation of opportunities for convergence and for learning for one another. And that's why I think this is such a wonderful opportunity for us to have a Congress and symposium together. Next slide, please. One of the aspects of variability that's important to recognize is, to some extent, excessive variability is really a proxy for poor quality care. So reducing variability really becomes a goal. And to that end, what are our opportunities to build consensus? I think we've got several resources, including clinical practice guidelines, as well as appropriate use criteria. I'll speak to each briefly. Next slide, please. The North American Spine Society has available online some really terrific clinical practice guidelines that I've contributed to, and many others have nationally and internationally, looking at specific diagnoses. So ischemic spondylolisthesis, spinal stenosis, degenerative spondylolisthesis, and giving guidelines that are evidence-based for appropriate management of general conditions. Now, for the individual patient, next slide, please, oftentimes the appropriate use criteria may be useful. And for the individual patient, we can actually judge the appropriateness of surgery. And again, where appropriate care is care in which the expected health care benefit exceeds the expected negative consequences of care by a wide margin, such that the procedure is worth doing. Now, in contrast, an inappropriate procedure is one where the expected harm may outweigh the expected benefits. Next slide, please. And this was quantified quite nicely by the UCLA group and an article by Fitch in the Journal of the American Medical Association, looking at this on a 9-point scale, where the most appropriate surgery are procedures where the benefit clearly exceeds the risk, and the most inappropriate are where the risks clearly exceed the benefit. Oftentimes in complex surgery, we're operating in a realm of reasonable. Next slide, please. To that end, we looked at this using appropriateness criteria for adult scoliosis, and the real drivers of appropriateness of surgery were patients who had more severe preoperative symptoms, Patients who had more of a progression of deformity rather than static deformity. Sagittal malalignment was a priority. And importantly, driving against the appropriate surgery were patients with major comorbidities or high risks of surgery. Next slide, please. So optimal care then is patient-centered care. And to provide optimal care, we need information on the natural history of disorders, the expected outcomes of care, be it non-operative and operative, and expected risks of care. And that's why it's so important that we carry on with outcomes research. Next slide, please. And of course, optimal care being very much focused on the individual patient and their conditions. Next slide, please. Please go ahead and advance the slide, if you would. We wrote about this as an international consensus that was sponsored by the AO Knowledge Forum for Deformity. And in this consensus, and this is quite worth looking at, we looked at defining the goals of surgery and what are appropriate goals. And we concluded with consensus that goals for improvement of neural status, improvement of pain, improvement of function were reasonable goals. We also identified some preoperative identification of risk factors, and there was clear consensus on identifying patients who were smokers with significant comorbidities, cardiopulmonary disease, osteoporosis. Where there was not much consensus is intraoperative strategies. So really not a clear guidance on when we ought to fuse to the thoracolumbar junction versus the upper thoracic, what we ought to do with pelvic fixation, when we ought to go circumferentially. And that's where further research really is needed. Next slide, please. So in terms of what can we and how can we improve and optimize systems, well, one part of this is developing interdisciplinary teams across the spectrum of care. And next slide, please. And for patients with complex spinal disorders, we recognize that there are multiple providers involved in these patients' care. Next slide, please. These providers certainly include the surgeons, neurosurgeons, orthopedic surgeons, but also non-operative specialists, pain management doctors, physiatrists, radiologists, physical therapists, and importantly for infectious disease and for tumors, our oncologists and our medical colleagues, our primary care doctors, and engaging everybody as part of a team. Next slide, please. Engaging everybody as part of a team, working together with a shared goal. Next slide, please. Just as any team would have with success. So I'm going to wrap up with these specific guidelines. Number one is preoperative considerations, the importance of assessing risk and benefit, assessing the appropriateness of surgery, aligning patient expectations with observed outcomes, and empowering patients to make shared decisions. One of the areas where we can optimize is preoperative medical optimization, smoking, nutritional status, obesity, diabetes. Many of these conditions are modifiable. Next slide, please. And I'll show you in real time what happens in my clinic. This is from my electronic medical record. And when I'm scheduling somebody from surgery, I simply type in a dot phrase, dot pre-op op, and it comes up with somebody's blood sugar. So I won't do an elective spine surgery on somebody with a hemoglobin A1C more than 7, somebody with osteoporosis, somebody with a body mass index more than 35, somebody with a serum albumin more than 3.5, active smokers, patients who are taking more than 50 milliequivalents of morphine per day, patients with reversible systemic diseases, patients without adequate social support, patients with untreated anxiety or depression, and patients who are frail. So only through screening for all of this can we identify problems, and many of these things are modifiable that I'll try and modify before doing elective surgery. Unfortunately, in many instances, surgery might not be elective, so we still need to operate, but for elective surgery, I'll try and optimize all of this. Next slide, please. And I think as we develop more predictive models, recognizing for the individual patient with specific comorbidities, with specific presentations clinically, what are the likely outcomes clinically, what are the likely complications, and what is the appropriateness of surgery? And as we develop these models, I think this will be an important preoperative goal. Next slide, please. Intraoperatively, having standardization, how we manage blood loss, how we conserve fluids, how we resuscitate patients, nerve monitoring, our surgical techniques. For most complex spine surgery at UCSF, we'll use 2 attending surgeons, and really trying to do our best to reduce complications with intraoperative strategies that are based on evidence, be it how we do pelvic fixation, where we what we do with our proximal segments, and avoiding PJK, and optimizing our chance of spinal union. Next slide, please. Just two more to get through here. Post-op considerations, managing pain, early mobilization, and Dr. Shirok is going to talk next about those type of intraoperative and post-operative considerations. DVT prophylaxis, avoiding delirium in patients after surgery. Next slide, please. And then finally, discharge, really making sure that pre-operatively we prepared patients to get home. They've got appropriate family support at home. We've got a nurse navigator who communicates with the patients, bringing patients back to clinic rather than emergency visits, and measuring our outcomes so that we can assess how well we're doing with different procedures. Next slide, please. So finally, in conclusion, complex disorders of the spine and spinal disorders in general present a significant burden to our healthcare economy and an important priority for our healthcare systems internationally. I think that optimal management, especially of complex disorders, requires an interdisciplinary team with reform that includes optimizing our non-operative pathways, preoperative optimization, intraoperative standardization, and postoperative accountability. And ultimately, what's needed is medical center investment into system reform and investment of surgeons as a priority for patient safety and for optimal patient care. So thank you for the opportunity to contribute to the Congress, and I look forward to further discussion.
Thank you, Dr. Barwin, for a nice presentation. I thank you on behalf of the ASSI. And it was nice to know that good outcome is a matter of teamwork and having protocols in place. Now I invite the second speaker, Dr. Alok Sharan from New Jersey, to talk about enhanced recovery after lumbar spine surgery, a concept of awake spinal fusion. Dr. Alok Sharan, please. Can you play the presentation? Sushil?
Hello, and my name is Alok Sharan. I am an orthopedic spine surgeon in New York and New Jersey, and I'm the Director of Spine and Orthopedics at NJ Spine and Wellness. I want to thank you for the honor of inviting me to speak today at the ASSICON 2021 meeting. I'm sorry that I can't join you in person, but of course, virtual is the next best thing. So I truly am honored to speak about our enhanced recovery program after lumbar spine surgery, awake spinal fusion. Enhanced recovery has made some tremendous advancements in surgical care over the past decade. Originally, ERAS was applied to GI surgery, but there has been, over the past few years, a broad adoption of ERAS principles in spine surgery. Originally, the goal of ERAS was to promote a faster and easier recovery. In spine surgery, the goal of ERAS has been to get faster mobilization of patients after surgery, better pain control with less narcotics, quicker discharge, and of course, an overall return to work, sports, and activity at a faster, more efficient rate. For the past few years, I have been performing a procedure called the awake spinal fusion surgery. Ultimately, awake spinal fusion surgery is an enhanced recovery protocol that allows patients to recover faster, mobilize quickly, with overall less pain. We have performed 135 awake spinal fusions to date. Our average length of stay for a patient who undergoes a single level lumbar fusion using our awake spine protocol is 0.8 days. 50% of our patients are able to go home on the same day, and about 70% of our patients are off of narcotics after 1 week. To perform awake spine surgery, our protocol entails, from the beginning, proper education of the patient, proper risk stratification of the patient, and from an anesthesia perspective, using spinal anesthesia and a novel regional block called the TILA block. Since we perform these surgeries using minimally invasive techniques, many patients don't require much narcotics post-op, and that's critical for achieving awake spinal fusion surgery. Now, anesthesia has evolved tremendously for spine surgery. The use of spinal anesthesia has been reported for many years now, And there have been a lot of good studies that have demonstrated the advantages of using spinal anesthesia versus general anesthesia. The novelty of the awake protocol, though, comes in performing this novel regional block called the TLIP block, Thoracolumbar interfascial plane block. First described in 2015 in the Canadian Journal of Anesthesia, the TLIP block is a regional anesthetic technique that blocks off the dorsal rami nerve and its branches in the interval between the multifidus and the lumbaris muscle. Typically, the TLIP block is performed using ultrasound to catch this interval. What we do is deliver medicine into this space over here. I typically use Exparel, which is Marcaine, which essentially lasts for 48 hours. On the picture on the right, you can see the ultrasound picture of the paraspinal musculatures. With ultrasound, we're able to find the plane between the multifidus and the lumbaris, and using a needle, we're able to essentially deliver medicine to that space. When performed properly, many of these patients have no pain or minimal pain after surgery. In the original study that was performed, the authors performed the TLIP block on healthy volunteers. They used ropivacaine 0.2%, 20 milliliters on each side. They measured their sensation and the anesthesia both at 5 minutes and 20 minutes after surgery, and you can see a dense anesthetic effect of performing the TLIP block. There have been numerous studies now that have looked at the use of the TLIP block in lumbar spine surgery, and then one of the first studies that were ever published from Japan, 72 patients were randomly assigned to receive general anesthesia versus general anesthesia with the TLIP block. Using 40 millimeters of levobupivacaine, performing surgery lumbar laminoplasty, the authors were able to lower the fentanyl requirement and lower the VAS scores in these patients. We've subsequently been using the TLIP block along with spinal anesthesia, and as you can see in this graph over here, we've been able to get a significant reduction in postoperative pain for these patients. Beyond the reduction in pain, though, many of our patients require minimal to no narcotics after surgery, with about a 76% reduction in opioid use. But what's been really exciting about the use of the protocol has been the fact that we've been able to discharge many of these patients home the same day. Our average length of stay now, as I mentioned previously, is 0.8 days for a patient who undergoes a single-level lumbar fusion. Here's a perfect example of a gentleman who had undergone our awake spinal fusion. This is Kevin. You can see his picture on the right-hand side. And on the left-hand side, you can see his MRI. Kevin had a herniated disc and had undergone a successful microcystectomy. Unfortunately, he re-herniated and developed degenerative disc disease. So the question was, should we perform a revision microcystectomy or should we perform a lumbar fusion? After a long discussion about the benefits and the downsides of each approach, we elected to perform a lumbar spinal fusion. And typically now, when we perform our awake protocol, about 4 hours after the surgery is done, we're able to get the patients up and walking, as you can see over here, where Kevin has about 4 hours after surgery, up, walking, getting ready to go home. And these are the kind of results that we're seeing now with this. Awake spinal surgery has been becoming commonly adopted now. There are, of course, many centers in the United States that are beginning to perform awake spine surgery, awake endoscopic surgery. But what's been great is that many of these centers are seeing similar results to ours, which is a significant reduction in narcotic usage and a significant reduction in length of stay. Beyond that, we're seeing significant international adoption of awake spinal fusion. I'm currently working with a group right now in England that's developing a awake spine surgery protocol. A good friend of mine in Italy is performing awake XLIX procedures. And many of you know that a few years back, I came to Pune, where we performed one of the first awake spinal fusion surgeries at Sancheti Hospital with similar type of results. So it's been great to see the adoption of this procedure overall. And now we're seeing greater and greater literature around this. A lot of published data is starting to come around the use of awake spine surgery. So it's been a major advancement now in spine surgery. To me, awake spinal fusion is essentially an ERAS protocol for lumbar spine surgery. I encourage all of you, if you're interested in learning more, to register for an online learning platform that we created called Doc Social, where we have on there a lecture about how to perform awake spine surgery. Thank you. I thank you again for the honor to speak today at the ASSICON meeting.
Thank you, Dr. Sharan, for a nice presentation on how to do surgery and fusion surgery under spinal anesthesia. We have the discussion and the questions at the end. I now invite Dr. Bala Venkat from Ganga Hospital to tell us about the current concepts of multimodal anesthesia and optimizing post-operative pain. Can we go ahead with Dr. Bala?
Good morning, everyone. At the outset, I would like to extend my very sincere thanks for giving me an opportunity to be a part of the annual convention of the Association of Spine Surgeons of India. Today, I'm going to share a few of my thoughts on a very pertinent and important topic in the perioperative care of a spine patient, the current concepts of multimodal analgesia and optimizing postoperative pain. I bring to you greetings from Ganga Medical Center and Hospital, Coimbatore. And as all of us know, postoperative pain is a combination that results due to both somatic and emotional component after surgery. The intensity decreases over time, and usually it is located in the proximity of the surgical lesion, can increase the risk of postoperative complication and delayed recovery if it's not taken care of. The incidence, the duration and the intensity of the pain varies considerably from one patient to another. There are several factors which result in this. Number one, because of the patient per se, and very importantly, now it has been noted, the pharmacogenetics and the pharmacogenomics of analgesic drugs working on a particular patient. For the same dose that we give, different patients of the same body mass index give varying results. Some of them have very good pain relief and some not. And now we understand this due to pharmacogenetics, which changes which happens in these patients, and it's a new topic for discussion. Next thing is the surgical procedure per se and the amount of tissue injury which happened. Third, how do hospitals respond to acute postoperative pain and how they've developed their acute pain service. And number four, the perioperative analgesic plan, and sometimes even the country and the culture matters in postoperative pain. Are we doing enough for our patients? Several studies have clearly indicated that acute postoperative pain is unacceptably high even in developed nations. I just wanted to share with you the ASSIST patient survey, which I was the principal investigator. The aim was to compare pain scores at rest and ambulation and to assess patient satisfaction between the different modalities of pain management at different time points after surgery. And this was an investigator-initiated prospective multi-centric trial from over 12 centers in India involving 1,046 patients, out of which 32% were spine patients. So the methods included pain scores, patients and caregivers' satisfaction toward postoperative pain, treatment and overall pain management at the hospital were captured at 3 different time points through a specifically designed questionnaire. And the conclusion was, this survey clearly indicated in Indian subcontinent that the current standards of care in postoperative pain management remain suboptimal, and that acute pain services, wherever it exists, is yet to reach its full potential for affording pain relief to our patients. Why should we insist on postoperative pain? It reduces, if the pain is unrelieved, it reduces the mobility, increases the stress and anger, and also impairs the respiratory function. It also produces immune depression, and there is metabolic hyperactivity and negative nitrogen balance, which will impair wound healing, and there is impaired bowel movement. And some of the visceral complications include myocardial infarction and ischemia, tachycardia, dysarrhythmia, thrombolytic events, metabolic acidosis, and significant peripheral vasoconstriction. And hence, the potential benefit seems to outweigh the complications. So improved rate of recovery, improved patient comfort, reduced morbidity, and faster discharge. And it's also been very clearly noticed that acute postoperative pain, if it's not relieved, it results in prolonged postoperative pain. There's an excellent article which shows that quality care has to be given, and quality has been defined as 6 domains of effective, equitable, timely, efficient, safe, and patient-centered measures, in which one of the most important thing is pain relief. Pain after spine surgery results from pain generators. And now the new concept is procedure-specific treatment to be offered in each spine surgery. So pain from the back actually originates from different tissues such as vertebra, intervertebral disc, ligaments, dura, nerve root sleeves, facet joint capsules, fascia, and muscles, which all generate pain. And the spine pain, I just wanted to emphasize, is we are fortunate that there is no visceral component, and everything, the pain perception is carried through the posterior rami of the spinal nerve, which gets connected to the sympathetic and parasympathetic nerve. A point that I just wanted to mention is there is a cross connectivity of these nerves, and that's why in spine surgery, sometimes apart from the local pain, there is referred pain that is happening. The types of pain is divided into nociceptive, inflammatory, and neuropathic. It's important to understand this so that we can go for a multimodal pain relief in our patients. So what do we do when we get to the spine patient? This is an excellent concept of preemptive analgesia. The night before surgery, in all of our patients, we put this to prevent peripheral and central sensitization. So on the day prior to the surgery, they get pregabalin 75 milligram, a non-steroidal anti-inflammatory drug like aceclofenac 100 milligram if the renal parameters are normal, 1 gram paracetamol, pantoprazole, and alprazolam to produce good sedation and anxiolysis. In some centers, they use statins for its anti-inflammatory effect. We don't use it. So this is on the day prior to the surgery. On the day of the surgery, the 0-hour medication is to augment the preemptive analgesia. So we use paracetamol intravenous. Ketorolac 30 milligram is given intravenous if it's the renal functions as normal. Dexamethasone 8 milligram is given for its anti-inflammatory property as a component of multimodal. Then we use opioids, and the drug of choice we use is fentanyl. So this is a 0-hour medication, and this is another component of preemptive analgesia. And once positioned, and the surgeons in our institution, the spine surgeons, do local infiltration with local anesthetic solution in skin and subcutaneous tissue to decrease the pain generation from this when the incision is made. The preoperative regional anesthesia nerve block, I think it's the future to decrease significant pain. I'm going to discuss with it in a minute later. And intraoperative analgesia is mainly dependent on opioid infusions, fentanyl and remifentanil, paracetamol, dexmedetomidine, and the drugs which have been tried in several centers across the globe. Apart from this is ketamine, magnesium, and lignocaine. We predominantly depend on fentanyl infusion, paracetamol, and dexmedetomidine. And postoperatively, to continue the pain relief, I think one of the significant issues in the postoperative period in spine surgery is the pain. And we have to evolve tools to know how much is the pain. And the best way to do is the numerical rating scale, the VAS score, and Magel pain questionnaire, and the new score for spine surgery is Roland Morris score. I would wanted the surgical team to discuss with the anesthetist the plan to assess the pain. So the intensity of the postoperative pain is directly proportional to the number of vertebrae involved in the surgery. Now, in a multimodal analgesia, you try to use various combination of drugs so that they collectively produce a synergistic effect. So on post-op day 1, they should get 4 grams of paracetamol, 1 gram paracetamol 6th-hourly, non-steroidal anti-inflammatory. The one which can be given intravenous is injection ketorolac, 30 milligram IV 8th-hourly, and pregabalin 75 milligram in the night, dexamethasone 8 milligram, a dose at 0 hours and after 8 hours. And apart from this multimodal therapy, you may use opioids as a rescue. And in patients in whom you don't want to use opioid, the weaker drugs like tramadol and tapentadol can be used. Slow-release buprenorphine patches seems to aid, and we use 10 milligram buprenorphine patch. Once you apply it preoperatively, it stays for a week, and it's a slow release and does not produce any respiratory depression. And the most important thing that has evolved in the last couple of years is ultrasound-guided regional block for our patients. Concept which I just wanted to speak in the last couple of minutes is the chest and the abdominal wall blocks, and this seems to offer the best component of multimodal analgesia. It reduces the pain scores in the first 24 hours, reduces the opioid consumption in the first 12 hours, does not produce nausea, vomiting, less sedation, early weaning from ventilator if you're ventilating your patients, and very short hospital stay, and less incidence of chronic pain. So what do you actually do? The intercostal block is what we do, and currently for all spine surgeries, it's the erector spinae block, where you deposit the drug between the transverse process and the erector spinae muscle. So here it is what is the drug is deposited. So this is a schematic diagram which shows between the transverse process and the ESM, if you place the drug here, it blocks both the dorsal and ventral rami and completely cuts off the pain sensation to the spinal cord. So this is how you place the drug between the transverse process and the ESP. And this is excellent for spine surgery. This is the sonoanatomy, the three muscles, the transverse process, and the drug will be deposited here. This has made a huge change and impact, and continuous erector spinae catheters can be placed in major spine procedures using elastomeric infusion pumps. The other thing that has evolved now is local infiltration analgesia called surgical site catheter, where the surgeon places the catheter inside the surgical wound and connect to an elastomeric infusion pump. This seems to be yet another mode of producing regional anesthesia at the local site as a component of multimodal analgesia. But a multimodal analgesia it means that more than one mode, which consists of paracetamol, non-steroidal anti-inflammatory drugs, pregabalin, regional anesthesia, and if in spite of this the patient has pain, then you go for opioid. Best is to go for opioid sparing. So effective pain control aided by the judicious use of different pain control therapies can significantly improve the overall success of surgery. Thank you very much for the opportunity, and I'm sure that from now on we'll get excellent results by incorporating multimodal analgesia in spine surgery. Thank you very much.
Thank you, Bala, for a very informative talk. May I invite Dr. Arvind Kulkarni? He'll be speaking on checklist for safe spine surgery. Arvind?
Yeah, good morning, everybody. Good evening. Checklist forms the backbone of major industries, major enterprises, and even household activities. In fact, the virtual meeting that we are having right now is programmed on a checklist. Checklist is basically an aid which helps in achieving success and prevents failure by compensating the weaknesses of human memory, forgetfulness, and distraction. It increases efficiency by adopting simple steps such as task and tick. COVID has shown us how to follow a checklist. For the last 1 year, each household and every surgeon has been following a checklist. Talking about hospitals, hospitals can be called disaster zones because majority of complications, mishaps that happen secondary to surgery are a result of a surgery itself. And out of close to 234 million people operated every year, at least 1 million die as a result of complication which can be avoided. So that's why the WHO embarked upon coming up with a checklist which has had a major impact. There is striking evidence to show that the infection rate is reduced by 50%, the death rate is reduced by 50%. Even Indian experience as derived from Dr. Shimran Nandi from Gangaram Hospital, whose unit adopted this particular checklist, remarked that this particular checklist is beneficial. So my own experience, this elderly gentleman underwent a laminectomy for cervical myelopathy. As soon as the laminectomy was done, he started bleeding from various sources. There was cluster bleeding, and which was uncontrollable. And to make things worse, our unit had forgotten to do a grouping and cross matching, and this sadly ended up in intraoperative death. Again, this is a common scenario. This happened with me, and the pedicle screw became loose. The pedicle hole was in bigger size when I tried to put a S1 pedicle screw, and we didn't have a rescue screw at hand, and we had to wait for the rescue screw to come. So the patient was under anesthesia for close to 1.5 hours till the rescue screw came, and so this was basically a waste of time and unnecessary exposure of the wound to pathogens and the patient to longer stages of anesthesia. Again, I do tubular surgeries, and the tubular set was missing when on 2 occasions because it was lying in some other hospital. So this is because in Bombay there is a general tend to get attached to various hospitals, and this was a very silly mistake. So why do such unpleasant things occur? Is it because of failure of expertise? Is it because of failure of super specialists? Is it failure of medicines, failure of sophisticated devices? None at all. This is all a failure of oversight, overconfidence, and a casual approach. So that is where the checklist makes a difference. The checklists do not teach you how to operate a complex case of scoliosis. Instead, they provide reminders of only the most critical and most important steps, the ones that even the highly skilled surgeons usually tend to miss. So there are other causes also like surgeons fatigue, etc. But the most important striking cause, for having such kind of unpleasant complications is failure of teamwork. Teamwork is very important. The surgery is like an orchestra. To save one life, scores of people, the nurses, the operating staff, the fellows, the residents, the surgeon, have to perform 1,000 things correctly in a stepwise manner and simultaneously for a successful outcome of surgery. That's why, surgical checklists make a big difference in major industries. The success of these major enterprises is solely because of following a checklist. So the WHO, as you see, came out with this very popular and well-established checklist, which has saved many lives across the world. However, it is generic. It is not specialty or subspecialty specific, which is very important because, like for example, spine has its own unique set of complications, that is wrong level surgery, which cannot be, which is a totally different, piece of cake. Now, surgery doesn't mean just the operation. It extends from the time of admission till the patient is discharged. So our checklist has 3 components to it. So the first component is very, very important in planning surgeries. So all the battles are first won in the mind. So all the surgical steps go through the surgeon's mind prior to surgery. That directs the success of surgery. So then is the intraoperative component, which basically includes the components of WHO plus components specific to surgery. And then comes the phase of complications. So we have designed a preoperative checklist, which goes to the patient's demographics, the necessary, paraphernalia that is necessary for surgery. Then intraoperatively, it is basically a check on antibiotics, positioning of the patient, the counts, the drain tug, etc. And then most importantly, which we included is the postoperative, which also includes the red flag signs that are explained to the patient prior to discharge, so that, if there is a complication, they come back to you, or at least get back to you on your mobile, etc. So this study we employ, basically we use the checklist in this particular period, 2018-19, and then compared the adverse outcomes with the preceding year. And this is, as I showed, this is a 37-point checklist, which covers the perioperative time. And there was remarkable, this 75% reduction in preventable errors in our unit. Our unit was already quite vigilant because we used to keep a check on everything. In spite of that, we could still reduce it by further 75% when we started following this particular checklist. So these are all the adverse events. You can see, preventable adverse complications from 56, it came down to 15. So 56 out of 393 patients had issues prior to implementation of the checklist, but this reduced to 15 out of 428 after implementing the checklist. And following a checklist is a routine for us. It is nothing new. You don't have to be stressed about it. We have always used checklist for pre-operative fitness, as shown on the left side, and we also have followed a checklist in response to an intraoperative mishap which was picked up by intraoperative neuromonitoring. So we are conversant with the utilization of a checklist. So why reinvent a wheel when WHO already has a well-established checklist? That is because spine is a totally different arena. Spine is a very complex surgery. So it reflects the height of permutations of combinations. There are different regions, there are many junctions, there are multiple levels. Again, there is right and left, then there are various approaches, then there are various types of surgeries, decompression, fusion, and if you fuse, if the patient has enough bone graft in himself, or do you need substitutes, or if you want to use components like bone cement for stabilization, etc. Then imaging is a very integral part of spine surgery, whether it is just C-arm, whether it is X-ray, or is it a complex surgery which needs navigation. So there are a lot of paraphernalia which may be necessary, and without which a simple surgery can become complicated. So these things have to be kept in mind, because absence of one particular gadget or infrastructure can ruin or lengthen the entire surgery and turn it upside down. So again, why a spine surgery checklist suits our milieu? Because there is significant stigma associated with spine surgery. We are always carry this on our back. That is a failed back syndrome, which is quite an infamous phrase. And again, the kind of complications we face are irreversible, unpardonable. Again, the amount of money that patient puts in from the pockets, if he's not insured, is tremendous. And if there is a complication, it multiplies ample number of times. Again, our OT boys, OT technicians, nurses are untrained many of the times, and so we use technology, and if they're not conversant with, you can end up in complications. And being in India, we face high volume of surgeries, so there is a lot of distraction. There is a lot of lack of concentration when you're operating on too many cases. Again, there is limited and bizarre distribution of resources. For example, in a population of 20 million in Mumbai, there are 2 or 3 sources of neuromonitoring. That is the kind of ratio we have. Again, we don't have stationary inventory in the operating room. We order implants, so there is possibility of a limitation from the vendor's point of view, which can have an impact on your surgery. Again, our fellows change, resident change, but the rules have to be the same. So that's why checklist is like a Bible for your unit. Again, unlike other countries, we have very poor and disconnected, surgeon GP algorithm in case a patient develops post-operative complications. So checklists bring discipline, checklists give guidance, checklists aid in decision-making, and checklists, most importantly, foster communication and teamwork between the surgeon, between the fellows, between the radiologists, between the nursing staff, etc., so that everyone, there is a team behind the success of surgery, and that is fostered by use of a checklist. So checklist allows surgeons to concentrate on non-mundane stuff. Checklist is application of knowledge we have consistently, correctly, and reliably. Checklist is making things happen correctly. Checklist shows that each problem has steps of solving. Checklist shows that each step is important. Checklist shows that the more you repeat it, the more you master it. Checklist reduces error making. Checklist reduces complexities. Checklist offers the possibility of verifications, establishes effective teamwork. It helps on effective utilization of resources and skills, helps to improve provision of quality services, provides customer satisfaction, and provides reminders of the most critical and important steps. So the next step would be to involve multiple centers to check the efficacy of this checklist. So this particular checklist that we're using is efficient, reliable, cost effective. Of course, there is a learning curve attached to its usage. It is definitely subspecialty specific, and we have seen that it reduces miscommunication among primary surgeon, training fellows, and the OT staff. And of course, it can be modified and it can be customized to your local operating milieu. Thank you very much.
Thank you, Arvind. If there are any questions from the moderators or the panelists? So let me start by asking Dr. Burman, how do you, I had written it on the chat also, how do you see that the normal routine activity of the other departments where you are taking the consultations from are not disrupted? I mean, how do you manage all that?
Yes, when we're creating interdisciplinary teams, it's awfully important to create pathways that are compatible with other workflows. So, for example, specifically between surgery and anesthesia in the preparation of a patient for surgery, we've actually built into the workflow part of the scheduling process is that I can order a consultation with the anesthesiologist prior to surgery. So for somebody who I'm concerned about comorbidities, so the anesthesiologist doesn't see the patient 1 or 2 weeks prior to surgery, but rather 3 months prior to surgery to really alert the anesthesia team. Smoker cessation programs, having an order set that automatically puts a patient who's an active smoker into a smoking cessation program. Pain management. I was very interested in Dr. Venkat's lecture from Ganga in terms of the interaction of anesthesia and surgery with regard to perioperative pain. So the subset of patients who are taking narcotics prior to surgery, especially higher doses of narcotics, making sure that those patients are seen by our perioperative pain service before surgery. So all this, I think, can be effectively accomplished with order sets that are built into the workflow.
Thank you. Thank you. Dr. Shankar, do you have any questions?
Yeah, I have a question to actually Arvind. Arvind, that's a very nice paper, and I'm also going to ask you to write on the checklist. But I have a problem with the checklist. The problem is whenever you duplicate a checklist, then there is always tendency to skip or error. As you know, in our hospitals, we have multiple checklists. The nurse has a checklist, the technician has a checklist, and our hospital has a detailed checklist. So when I heard your lecture I think a year or so ago, when I tried to introduce a new checklist, ultimately what happened is that all three became incomplete. So what's your suggestion? Because hospitals have their own system, and we have an HIS inbuilt computerized system. And when you these systems are so integrated that when you want to introduce any extra thing into these systems, there is resistance from the EMR developer or the EMR people. And I would also request Dr. Burman to have a comment, or anybody, or allowed to make a comment, or anybody to make a comment. When you are in an individual setup, or if you have your own hospital, you can easily introduce a checklist which works for you. But when you are a multi-speciality hospital like ours, what do you do?
So our checklist is not integrated to the hospital at all. I go to 3 hospitals. So this is worked on my fellow's laptop. So right from the day a patient is suggested surgery and he agrees for surgery, you start ticking in, because even intraoperative monitoring in Bombay, we have to sometimes book about a week to 10 days in advance. So this has nothing to do with the hospital system at all. It is our own institution. Our unit is an institution in itself. And when that particular fellow is washed up, the other fellow sees to it that, the intraoperative details are checked in. Whether you've done a final tightening or not, whether drain tug is done or not. So at every step, we make sure that this is done, and this keeps repeating itself. So the only issue is when one of these fellows is on leave or things like that. So it gets a bit compromised. But as much as possible, it's very simple and easy to follow.
Yeah, I understand that. That's only one checklist, but we have to fill our hospital checklist. Just as I'm having difficulty with my fellows putting in the ASSI data in the Bharat Dave's registry. They say, sir, we are having a duplication of things because we have to put it in our hospital system before coding can occur, and then we have to again upload in the ASSI website. And I've tried my best.
The problem in India is typically two things. One is healthcare essentially means surgeon care. It means nothing else. There is no responsibility either of the paramedical staff or the orthotists or the physiotherapists. And therefore, the load of delivering all this, if you introduce a safety checklist, it's going to be your headache. It is not the headache of the hospital. And the only way is if the hospital, rather than you talking to nurses, actually decides. The same problem I had when I started the ERAS program in Jaslok Hospital about 5 years ago. And what happened was that the pressure to deliver is entirely on the surgeon. Sometimes the anesthetists are not comfortable with euvolemia, so then it becomes difficult to deliver this kind of care. So therefore, we found that this is the biggest hurdle in India, that the whole responsibility for the healthcare is not divided among nursing staff, administrative staff, etc. It is entirely dependent on the surgeon. And therefore, if you're going to do checklists, 100% you have to do it, or at the very least, it is your second in command or your fellow. Beyond that, you will not be able to actually implement it in most hospitals under the circumstances that we work in. However, let me ask a question to Dr. Bala Venkat. Sir, what I find is it is extremely difficult to plan analgesia for elderly individuals above the age of 70 or 75. Their tolerance to most drugs is very, very poor. And invariably, I find that we eventually end up giving them less pain relief than they deserve. And how do we overcome that? I find pregabalin is extremely poorly tolerated by most of my patients. If I give pregabalin to a patient, especially it's a woman, and especially if it is an older woman, 100% they will call me up that I've got nausea, vomiting, headache, giddiness, and the phone comes to you. That's the last thing a surgeon wants, that he doesn't want phone calls from patients for all this bullshit. So how does one avoid all this?
I think, thank you, Dr. Gautam. I think one of the most important thing which has happened in the last couple of years is incorporating regional analgesia to all your patients, especially geriatrics. And we had a nice talk on thoracolumbar interfacial plane block, which Dr. Alok mentioned, and also the one which I mentioned, which the surgeon can perform themselves, even if the anesthetist doesn't want to do. All that is, you need to deposit the drug between the transverse process and the erector spinae muscle. I think this is the best answer to your question, in that it considerably reduces the pain, and especially when we add an adjuvant of dexamethasone to the local anesthetic solution, we don't have exparel like what Dr. Alok has. That is a liposomal bupivacaine, which we don't have it in India still. So if we want to prolong the duration, the local anesthetic with 4 milligram dexamethasone on either side. So bilateral ESP seems to be the answer for your question. Along with this, the safest is paracetamol. If they have no contraindication, like 1 gram 6-hourly is the ideal dose for surgical analgesia. So these two things will do the trick, even if you don't want to give a non-steroidal because it's a geriatric patient.
Can I ask one question to Dr. Bala? Maybe Dr. Alok Sharan can also contribute to it. So usually in my unit now, people have started doing endoscopic surgery. So the problem, the patient is placed in prone position, and in local anesthesia we are doing. Many of the patients, they are not able to tolerate that prone position, more so the elderly, they start moving. So do you have any protocol for that? You give either sedation or some medication during that period? And even the Dr. Alok Sharan is doing fusion, fusion in awake. position. So have you seen this problem? Positioning the patient in prone, sometimes they are not comfortable.
I think Dr. Alok will have to say this, but we don't do it in awake, sir, except for vertebroplasties and high-risk critically ill patients where we avoid GA. But most of our patients, as you rightly said, lying down in prone position has to be very selective because especially in obese and geriatric patients, and some of them are very anxious. So I think Dr. Alok will give more insights into this. Patient selection will be very crucial when we want to do awake spine surgery in prone position.
Thank you. Thank you for the question. Can you hear me?
Yeah.
So it is very challenging. I think first and foremost, you have to discuss it with the patient if they can tolerate being prone. So I ask them, do they sleep on their belly at night or do they sleep on their back? And if they do sleep on their belly, do they have any problems? So that's the first question. We use a Wilson frame for both our laminectomies as well as for our fusions because we find that with the Wilson frame, the patient has more support as opposed to using a Jackson table because they feel more scared. So that's the second thing. Third is that when the patient is prone, it's critical that they don't get disinhibited. So I don't like using propofol, for example, because the patients get disinhibited. At most, we give a little bit of Versed and we give some Benadryl, and we find that they're okay if they're a little bit sleepy. There's a medicine called Precedex also. So we find that actually is very helpful to keep them in a position. You never want them to be disinhibited because at that point, that's when they start to move. So you want them to be, they have to forget about the surgery, but not at the point where they can't respond to your command.
Thank you, Dr. Sharan. I think we are running out of time and we need to end the session to begin the next one. I thank all the speakers for their excellent presentations and all the moderators and all the questions that enrich the session. Thank you, and we end the session now.
Thank you.
Thank you.
Thank you.
I invite Dr. Gautam Zaveri to take over and invite the next moderators.
Thank you very much, Dr. Barwan, for joining us this Sunday morning India time and delivering an excellent talk on behalf of the UCSF. I thank Dr. Alok Sharan. I think this is a field which is becoming more and more exciting for Indians here, with a lot of people doing microendoscopic and endoscopic surgery. They would like to know more about awake surgery, and I'm sure they will be going through your website in order to see how to perform these kind of surgeries or be in touch with you over email to try and get more information. Dr. Bala Venkat, I think you've given us a very nice protocol, including actual figures as to how to go about perioperative analgesia. Again, sir, I'm sure a lot of people will contact you regarding this. Arvind, I think you focused very nicely on safe surgery, the need of the hour, when on one hand we are talking about safe surgery, the need all over around, and on the other hand, we have some basic problems, the need for a checklist, and the emphasis on that was very well found. Thank you very much. If gentlemen, if you can stay for another 10 minutes at least on this, there may be lots more questions. Like Dr. Basu, please direct your question on the chat box, and I'm sure they will be very happy to answer that. And without much further ado, let me invite the moderators for the next session. The next session in this room, Dr. Ankur.
Yeah, I think I'll take over. Dr. Shankaracharya and myself have to moderate the session on ASSI multicentric trials, the report that we are putting up. Is that right, Ankur?
Yes, sir. That's correct.
Yes. Right. So we would request all dignitaries to stay on for this session because we need your inputs on the protocols that we are going to present on the multicentric trial. I think in a trial, the most important part is the trial design. And if you falter on the trial design, everything will go haywire. So that's why we present the protocols, and in the subsequent meeting, we present the outcomes of the trials which have been going on. In the last meeting, we also presented the outcome of our various trials. Some of them are getting published and others are in the process of getting published. And I would only want to say that the research committee wants to invite as many proposals from members as possible. There will be a template according to which the members need to submit their proposal. It will be evaluated by a panel of members, and the best projects will be taken up for multicentric trials subsequently. If you need any further details, you could contact us, and we'll be happy to let you know more about this. So, Shankar, with your permission, we will start the presentation on characteristics, management, and outcome of culture-negative pyogenic spondylodiscitis, a systemic review and multi-center retrospective case series based on which Dr. Naresh Babu has designed a protocol for a multi-centric trial. Can we have the video, please?
Good morning. So I will be presenting my proposal for the ASSI multi-center research project. This is on characteristics, management, and outcomes of culture-negative pyogenic spondylodiscitis, a systematic review and multi-center retrospective case series. So we all know spondylodiscitis is the concurrent infection of the vertebral disc and the adjacent vertebral bodies. In the most patients with pyogenic spondylodiscitis, the clinical and imaging features suggest a presumptive diagnosis before we can actually confirm the microbiological pathogen. But microbiological studies, many times they remain inconclusive. The rate of negative microbiological studies can range up to 20% to 79% of the patients, with the typical features of pyogenic spine infection. So we identify a pyogenic spondylodiscitis patient basing on the clinical features and also MRI. But once we try to obtain the culture, we tend to get very low yield. That can be up to 79% of the cases. Given this scenario, we are forced to treat these patients either by broad spectrum antibodies or repeat biopsies or repeat cultures. Or sometimes you can embark on the patients, so we can encounter the patients who are actually started by some vague broad spectrum antibiotic before the patient actually reaches the index, the primary surgeon who are operating on that. So then also we tend to get a negative microbiological study. So how to deal with this scenario is the main focus of my study. Currently, there is substantial lack of structured reviews about this topic. The clinical characteristics, how they differ between the culture negative spondylodiscitis with the culture positive spondylodiscitis. The course, when you don't know the antibiotic, which antibiotic to be given, how the course behaves, and what was the management done in these patients, and outcomes, whether they differ once we identify a specific pathogen and treat them accordingly, or the results are same when the broad spectrum antibiotics are given. So that is still unknown. So the aim of this study is to systematically review the available literature in order to determine the main features of the culture negative pyogenic spondylodiscitis. So to answer this research question, so we wanted to conduct the study in two parts. First, initially understand the literature, what has been reported in the existing literature now by doing a systematic research, search of Medline database. So we do it by PRISMA guideline recommendations, the clinical features, the laboratory data, radiological science, treatment strategies, and outcomes will be summarized by obtaining this articles, and the study's quality assessment will be performed using the JBS critical appraisal checklist. Once in the part 2 of the study, once we know the existing literature on the asymptomatic and culture negative spondylodiscitis, retrospective multicenter case series will be started in the side arm, where the demographic data presentation, location, imaging findings, and antibiotic of choice, and how did the duration and the course of the disease go, and how many patients needed surgery, when was the transition from conservative to surgical happened, and the outcomes at the end of the disease, and the complications will be summarized. So this is my proposal for the study. I request your valuable inputs and suggestions to go forward. Thank you very much.
Any points? Yes, sir. Dr. Rajashekharan, sir.
Naresh, thanks for bringing up this important topic. But you need to bring homogeneity and standard into what kind of culture is being done. Is it a usual culture or routine cultures, or are you using special culture media, extended culture? How much of tissue is being sent? There is a lot of variability within this that will affect the outcome.
Agree, sir.
You have to mention about what is the antibiotic, and all strict protocols on whether the patient has had an antibiotic even 1 week before. It's not enough to stop these antibiotics for 48 hours or 72 hours. So the concept is good, but the trick is in the devil of trivialities and accuracy of the protocol. So you need to write a very detailed protocol. This is very superficial, but the concept is really good, but you need to really write a very good protocol for this.
I believe, Naresh, once you do the literature review, right, but these things will become very evident. I think what Dr. Rajashekharan sir has mentioned is very appropriate, because unless you standardize the culture protocol, then it would not be because especially in a multicentric study, these things become very important. So
also inclusion criteria.
So
inclusion criteria is very important.
Can I make one? Done the literature review, we could have again a review of the protocol. If we can do that on a priority and then begin the study, it would be great. Dr. Srivastava wanted to say something.
I see.
Naresh. We give Naresh first time to respond.
Yeah, I just wanted to make one thing in the heading. Instead of telling negative pyogenic spondylodiscitis, it will be better the clinical radiological diagnosis of pyogenic, because histopathologically you might find something. What I feel, the material which you are sending for culture, I think simultaneously that we might get surprises. So I think in the term which you are mentioning in the heading, a clinical radiologically diagnosed case of pyogenic spondylodiscitis. Because how do you say that it is pyogenic spondylodiscitis? Because you don't have proven culture. So on clinical radiological, base, you are telling that. I think that word should come.
Naresh, what do you have to say for both the suggestions?
Got it, sir. Sir, thank
Your voice is breaking, Naresh. Maybe connectivity issues just happening.
Nice inputs from sir. Actually, that was the main. It looks like prospective systematic review.
Can I add something, sir? Bhavuk here.
Yeah, sure, Bhavuk.
So I think we should go for MOOS guidelines here, because we are observing the findings. We are not doing any active intervention. Prisma is basically for interventional studies. So I think we should go for MOOS guidelines.
Fine. Okay with that. So.
Sure.
But Prisma holds true also if you are not going in for an intervention, right? There are separate subsets for that.
Prisma is basically, sir, preferred for intervention only. MOOS is for the studies.
Okay, we could, Naresh could look into that. Any other suggestions?
As I said in the committee meeting also, Naresh, you really need to look at which of these spondylodiscitis have actually got antibiotics prior to this, because I suspect that most of the, as it is multi-center, you could actually have a strict control over 1 or 2 centers, but if you...
Yeah. Yeah, I agree with Basu, because inclusion criteria will become very, very critical, because we could have had some cases where we don't know the antibiotic history. They may be shifted from a different institution, and if they are not taken exact details, then it will confuse the whole issue. Okay.
Another issue is the fungal pyogenic discitis. Sometimes it only comes up in pathology, and a lot of times, unless you have sent, just because we sent all are for culture and biopsy and histopathology, sometimes they may not be sent for histopathology, and that also may confuse, and later on that may get. So the characterization of the study and what these centers send are important, actually, as everyone said.
So, Naresh, based on suggestions, would you want to explore rather than only a culture negative, right? Means histopath also included within it.
Sure, sir. That's already included. What I suggest is where I'll go through the systematic review first, and then basing on the results, what you identify in the systematic review, I would prepare a protocol.
Right.
Looks like we may not be able to do a properly retrospective study, so we may need to do a prospective base.
Yeah. It is important to do a prospective study, and I think we'll have time for that. Prospective studies are to be preferred, especially in multicentric studies, because then you can standardize the protocols and come out with better outcomes. So, any suggestions on any of the on the study per se? I think what Bhavuk would be very important is if we could do a review as early as possible. Amongst us present the review, and based on that, if there are any suggestions for incorporation of within the protocol, and based on the suggestions today, we'll finalize the protocol, right? And I believe rather than retrospective, we make it a prospective. Janardhan, yes?
Sir, I also agree with that we need to do a prospective study, because we have done in our own center, as I mentioned in the committee meeting, we have done one study, and we presented it in a conference also. A lot of limitations, like prior history of antibiotics was not clear. And then we have not done a fungal culture in all these patients. So there was a suggestion that some of them could have been a fungal osteomyelitis, then you could have missed it. So a prospective study would be better.
And points well taken. If there are any other learning points from your study, please do share them with Naresh.
Yes, sir.
So that we can, as we discussed before, having a good protocol is the most important part of the entire study. Otherwise, at the end of a year or two, you realize that the entire effort has gone haywire. So that is the importance of discussing it here. Shankar, any comments on this?
No, I agree with your comments.
So if that's it, we'll move forward to the next study, which is comparison of functional outcomes following discectomy between global disc degeneration and selective disc degeneration. Dr. Janardhan Ayathala.
Good morning to all.
First, I would like to thank the president of ASSI for making me part of this ASSI multi-center study. This study is a part of disc degenerative disease group. The title of my study is Comparison of Functional Outcome Following Discectomy between Global Disc Degeneration and Selective Disc Degeneration. The tentative participating centers, these are the tentative participating centers. I have contacted some of them and they have agreed. In the meantime, if any other centers who would like to be part of this study, they can definitely consider joining this group. Discectomy for lumbar disc herniation is an accepted method of treatment in select indications. While the relief of the radicular symptoms is predictable, relief of back pain and progress of degenerative disc disease is unpredictable. And there are various factors which can affect the outcome. Some of the factors which can lead to poor outcome include long duration of symptoms, severity of pathology on MRI, comorbidity, psychological factors, work-related factors, smoking, etc. Among this, our area of interest is this one, severity of pathology on MRI or MRI changes, or I would like to say the extent of disc degeneration. So when we talk about disc degeneration and the factors that affect the outcome, these are some of the factors which has been considered in literature. Size of disc herniation, contained or extruded disc, severity of disc degeneration as evidenced by the Firman grading, and the number of levels with disc degeneration. While there are quite a few studies which have dealt in detail about the size of the disc herniation and whether the contained disc or extruded disc carries good prognosis or bad prognosis, the extent of the disc degeneration seen in the spine and its relationship with the functional outcome following discectomy has not been studied in detail. And this idea has come from the this particular paper which was published by Ganga Hospital Group. They have identified two distinct patterns of disc degeneration. One is one group consisting of patients who are having disc prolapse with isolated 1 or 2 levels of disc degeneration restricted to the lumbar spine, and another group of patients who have got extensive disc degeneration spread across the entire spine, which we can label it as a global disc degeneration. So in many of these patients, irrespective of the type of the disc herniation, say something like this, where we can see that there is a disc herniation in L5S1 in one of the picture, and another picture shows 2 levels, but the rest of the discs remain relatively healthy. On the contrary, you can look at this, where again there are no disc herniation noted in L3-4 and L4-5 in both the cases with the canal stenosis. And you also can notice that extensive disc degeneration involving the entire spine. And both these patients are relatively young patients. The one on the left side is just 32-year-old. On the left side and the right side is about 48-year-old. So discectomy is done for symptomatic disc herniations irrespective of the type of disc degeneration or disc degeneration pattern, whether it is isolated level or global level. But then there are no studies whether the discectomy has similar outcome in both these groups. Whether the disc degeneration pattern has any effect on the outcome is not studied well. Our hypothesis is patients who have global disc degeneration can have poor functional outcome following single level discectomy. So the objectives are, the primary objectives are to study the percentage of different disc degeneration patterns, global or limited, in our patients who undergo discectomy, and then compare the outcome of discectomy between these two groups. Our secondary objectives include to correlate between severity of disc degeneration and functional outcome after discectomy. This is our plan is to do a prospective study, follow-up of 1 year duration. All patients between 18 to 60 years, that is the working group, are involved, and who undergo single discectomy are included. These are our exclusion criteria: diabetes mellitus, associated degenerative disc disease, revision surgery associated with deformities of the spine. After patients are enrolled into the study, they are classified into 2 types. Disc degeneration limited to 2 to 3 discs is one type, and the other type is disc degeneration involving thoracic and cervical spine. Our sample size is 150 patients in each group, plus about 15 patients to make up for the loss of follow-up. After obtaining the ethical clearance, every patient from each participating center will be enrolled. The disc degeneration pattern will be classified by the operating surgeon initially in consultation with the radiologist. Once the number of enrolled patients reach the target, further enrollment is stopped for that group. Patients undergo discectomy after enrollment, and after discectomy, they are followed up at 3, 6, and 1 year. The data collected include preoperative assessment data like baseline data, neurological status, WAS, MRI, etc. The MRI classification can be done once again by the chief coordinator after the data is submitted to the chief coordinator. Variables, which I'm going to discuss again. The outcome is assessed based on VAS score, ODI, Roland Morris Disability Questionnaire, patient satisfaction, and complications. These are the variables of interest which we need to consider because they can affect the outcome. And statistical analysis can be done using descriptive statistics, t-test for comparison, and regression analysis for variables. Thank you.
Hello. So, house is open for discussion. Yes, Amyajit?
2-3 observations, sir. First is, it is mandatory to rule out associated stenosis. Many patients of discectomy, especially in the elderly age group, have associated stenosis, and this has to be an exclusion criterion. That's one.
Agreed. And
second
it's not only Samajit, elderly, you may have congenital canal stenosis associated also in young people.
That should be a very important exclusion
and
criteria.
syndromic like achondroplasia, etc. also need to be. Yes. So that would be an exclusion criteria, I presume, Janardhan?
Yes, sir.
Next is 2 to 3. Janardhan, you've said that it is 2 to 3. I think it should be 1 or more than 1. So you have taken one group as 2 to 3 levels of disc degeneration and the other 4 to 5 or so, whatever it is, more than 2 to 3. So that is a very flimsy sort of cutoff. So that has to be sharpened and a protocol better set up. That's my second observation. The third observation is that...
Somebody discussed that. Janardhan, was that based on the Ganga study or... I don't think it would have been just a criteria just laid down by you, but was it based on some pre-existing evidence?
No, I think sir would like to.
To clarify on this because the study which we published is completely on a different angle.
Right, sir.
And on this study, I'm just looking at whether at the end of doing a multi-center trial, we would actually conclude what is already well known and obvious, to state the obvious. Right. So even before the study, all of us know that a patient who is having a single level disc herniation, his outcomes are completely different from a person who is having a multi-level disc degeneration. So I'm sure that at the end of the study also, the study will conclude people who are having multi-level problems are having poorer outcomes. So, I mean, I'm not really sure what is the end point, or what is the point you're trying to prove, Aitala?
Sir, would like to know whether the outcome of discectomy is satisfying to the patient, single level discectomy in these patients when they have an associated global disc degeneration.
Yeah, but we always know that these people, if you carefully select them to operate only when they have a radicular pain, and we always counsel them, you have a multi-level disc degeneration, so your back pain may not go, but you will be solved of your radicular pain, isn't it? I mean, that's an obvious knowledge and statement.
I think what I also could draw from the literature was that if we, at the single level, if we study whether it is, I took it as a global, as at that level, if there is a generalized disc with a radicular symptom vis-a-vis just a paracentral disc, would the outcome be different? I'm not sure if that has been published well. But as Janardhan has said, I'm not sure if it has been published whether with multi-level degenerative changes, would the outcomes be the same or different?
No, this has not been published, sir.
Yeah, that's what I was under the impression.
This was,
can we...
Outcome of discectomy is not published, sir.
Right. Just specific this before we move forward, if there are any points.
So just regarding this clarification regarding the classification, actually I was thinking of making it single level only, but then we have noticed that many times it is actually 1 or 2 levels. We cannot say specifically, then we will be losing a lot of patients. Whereas even those patients who have got 2 levels of, like one example I put it in my presentation, the rest all discs were completely normal. So where do they stand? That is another issue that I was also like.
I have one point to make. Can I make one point?
So should we restrict it to say those who are having a lower lumbar level versus those who are having the thoracic and cervical also?
Fine. Somajit, Naresh, and then Shankar quickly. Somajit, you were saying something.
Yeah, the third point I wanted to make is that
no. Let's close this point, Somajit.
Okay, so Naresh, I will not participate. Let the discussion go on.
Naresh, you had anything regarding this point? Or
no, I have, after reading the title, I was under the impression that what you are trying to say, that we are going to compare the results of discectomy at that level, where there is a limited degeneration, that particular disc compared to the entire disc degenerated.
Yeah, that's what I thought.
That was the impression which I got from the title. But this is something different. I'm not very sure if you say global degeneration, or should we say something like multi-level degeneration. As SARS clearly said, the outcome of the study seems to be already known. So how do we going to get, what else we are going to get extra is a big question. If there is no result, no study which is published on like Firman 1 discectomy compared to Firman 4 or discectomy, that may be a better study. That was my impression when I read the title first time.
Yeah, the title itself is very confusing. I think Sig wants to say something. Yeah, Sig.
Thank you for the opportunity to contribute. Awfully important study, and I was just typing a comment is I may suggest that rather than having the focus of the study being outcomes of global versus focal degeneration, rather having that to be a single predictor variable and looking at multiple other variables and do a multivariate analysis to see what extent the radiographic parameters of focal versus global may fit in as a predictor compared to other factors, for example, back pain versus leg pain, or the magnitude of the disc herniation, or the mental status of the patient, for example. There's a lot of other variables that may predict poor outcomes. So just using that as one of many variables.
Yeah, I think that's a very good point. Yeah. So we need to have clear outcomes and clear inclusion criteria.
Yeah, could you get that, Janardhan? You will have many factors which will affect the outcome. So all those confounding factors need to be taken into consideration. And
yes, sir. That has been included as variables. Maybe we can include it as primary variables and then design a.
Yeah. So
maybe we will make changes for the design as.
Shankar, you were.
I was just saying what Dr.
This point. Yeah.
No, I was just saying what Dr. Berwin said, that we know that the outcome of a disc prolapse is dependent on what type of disc prolapse also it is. Whether it's an annular bulge, whether it's a sequestrated fragment, whether it's an end plate fracture, where is the disc prolapse, what is the patient psychology. So just making it global versus single, we may not come to the end point, or we may not know anything. So that also, all those things have to be looked into. So multivariate may be much better than a single.
So I think, yes, sir. Please go ahead.
No, I would actually suggest that they all must present a full-blown protocol before they come on to treat, because
yes, sir, we had discussed this. There was some confusion there, but next time it will be done better. I think the first step is to do a literature review, right? Systematic review. Based on that, draw up a protocol and then have it finalized and then present it here. So, okay.
Go ahead.
Right. Somebody, you had some other points on this.
Also, we need to restrict to a single level discectomy, and the procedure of discectomy also needs to be completely analyzed, because if it is a prospective study, if you're looking at, as Sig suggested, that it's a much better study if you say try to assess the parameters over which a single level microdiscectomy with in a patient would do for these multiple variables. So the operative procedure also has to be absolutely standardized.
Yeah. So that will need to be standardized. Agree. But we could compare. If it is we will need to see what would be the sample size required if we have multiple operative procedures compared. That could be one of the variables that could be compared, right?
Yes, sir. Then we need to increase our sample size based on the number of variables.
So all confounding factors need to be taken into consideration. And then with the help of a statistician, we need to decide what would be the sample size required and then move forward in this regard, right?
Okay, sir. Yes.
Right. So that's it. We'll move forward with the next proposed study, evaluation of predictors affecting shoulder balance in adolescent idiopathic scoliosis patients and the effect of corrective surgery. Dr. Bhavuk will be presenting this.
On behalf of ASSI Multicentric Deformity Study Group, I thank ASSI for giving us this opportunity. And as part of this deformity study group, we have already completed one project, which was cervical sagittal alignment changes in the LANK1 AIS and its alteration with surgery. And this we started as well as completed last year only. And the manuscript is already submitted to the Spinal Deformity Journal, which is the official publication of the SRS. And it has also been accepted for the podium presentation in IMAST this year. We are planning a new study this year, which is the evaluation of predictors affecting the shoulder balance in EIS and the effect of the corrective surgery on it. This will be is important because we know that the shoulder imbalance as such is quite overlooked and undervalued. However, if we think of from patient point of view, the shoulder balance is quite important because of the better aesthetic and improved clinical outcome after the deformity corrections. There are some papers which have tried to look the evaluation predictors of the shoulder level after spinal fusions, and they have recognized the importance of the correction of the distal thoracic curve, where comes the importance of harmony as well as the overall alignment of the scoliosis after the correction. So the aims and objectives of this study will be to investigate the effect of the coronal imbalance as such in the overall AIS patients, to study the difference in the shoulder asymmetry among various Lanke subtypes, and to assess the effect of deformity correction surgery and the UIV on the shoulder asymmetry in these patients. It will be multicentric retrospective observational studies. The patients with AIS will be enrolled as per the inclusion and the exclusion criteria. These will be the standard criteria. The first objective will be to investigate the effect of the coronal imbalance on the shoulder asymmetry. So we are going to obtain the whole spine standing scanogram X-rays. We are going to use the SurgiMap software. We are going to assign the negative value for the higher right shoulder and the positive values for the left shoulder. And they will be divided into two groups, the left shoulder higher or the neutral, and the right shoulder is higher. And then we are going to compare the various factors among the two groups. And we are also going to combine the overall, the magnitude of each curve, the severity of curve, and the relative magnitude between the curves. We're going to compare, and the severity of curve we are going to define as the sum total of the left deviating curve, that is the proximal thoracic and the thoracolumbar curve minus the main thoracic curve. This is for we are assuming that the AIS type is the right, main thoracic curve is the right-sided one. And the relative magnitude we are going to define as the ratio of the main thoracic and the proximal thoracic curves. So we are going to use the different radiological parameters as defined in the literature. Like the T1 coronal tilt, coracoid, clavicular angle, clavicle rib intersection difference, first rib angle, as well as the coronal imbalance as such. And these are the various parameters which we are going to use. The second objective will be to assess the effect of the Lanke subtypes, and we are going to always also compare the various radiographical parameters between these types. The third objective will be to study the effect of the corrective surgery as such on these parameters. We are going to follow up, use the post-op radiographs at 1 year follow-up, and the UIV we are going to define, and the various parameters again we are going to compare between pre and the post-op analysis. We are going to use the standard statistical analysis between these things. So I thank ASSI for giving this opportunity, and we welcome all the centers who want to participate in this multicentric trial. Thank you all.
Respected Chair.
So this house is open for discussion now. Any points that anybody has? Yes, Amijit.
So Bhavuk, you have completely sort of restricted yourself to radiological shoulder balance. Don't you think that this is goes hand in hand with the clinical shoulder balance? Because the many a times and many a paper has described the difference between the two.
Agree, sir. We can incorporate that thing also. And I was also thinking when I was presenting this thing that we can include the shoulder. So, but the problem is that we will have to get the appropriate clinical photographs from all the centers, which may not be possible, to look at the closer photographs of the shoulder in these patients. So if the panelists think that we should include them, we can include that.
I would strongly suggest that you include clinical shoulder balance, because clinical shoulder balance, including the medial shoulder and the lateral shoulder, have been extremely well identified. And this is what the current deformity study groups are focusing upon, rather than the radiological shoulder balance.
Okay, sir. Agree. Any other points? Bhavuk and Samit, sometimes the shoulders may have a balance, but clinically, means because of the rotation, right, it doesn't give an appearance of having a good balance. I'm not the true expert in this. Wanted to know your opinion on that.
I didn't get your point.
Because the rotation doesn't sometimes get corrected as much as the coronal balance.
Okay.
You may have a very good level shoulder, but clinically it doesn't give a good appearance because one shoulder is ahead of the other because of the rotation, and the cosmetic effect is not as good. Is this well described in the literature? That's what I was.
So this is extremely well described, and that's why the concept of a medial shoulder height and a lateral shoulder height is coming. The lateral shoulder height is more at the level of the acromion, whereas the medial shoulder height is the silhouette, where the neck actually goes into the shoulder, and that is very much directed by the rotation of the proximal 2-3 vertebrae and the trapezoidal hump. In many a case, the radiological shoulder is well maintained, the lateral shoulder height is well maintained and symmetrical, but the patient is not happy because the neck merging into the shoulder, the skin silhouette is asymmetrical on both sides, and it is purely because of rotation and the trapezoidal rib hump.
So haven't we come out with any radiological parameters also to document that, like an oblique?
So there are multiple radiological parameters. I've written about shoulder balance in the last AIS Symposium on in ISJ, and Bhavuk can refer to that. I'm sure he's gone through that because we had a discussion on this, and those can be incorporated, sir.
So Bhavuk, if we are doing it, it becomes very important that we include the clinical parameters as well and all of these. So because by the time the study comes out, I'm sure there will be much other documentation and in this regard, which will be available.
We will include, sir.
Yeah, Naresh.
Yeah, so Bhavuk, a nice design. I think this is what we have discussed before also. Then the main aim of the study will be like the shoulder is not the function of proximal thoracical. That's what we may end up in proving. It's a function of lumbar plus proximal thoracic, or the severity of the main thoracic, which compensate the proximal thoracic. So as we are doing the shoulders, maybe is it worthwhile to also look at the iliac crest or the flanks, so that that can be a part of second study. The same data set can be used for the lumbar things, and then we can come up with multiple. Just a thought, you can just go on adding parameters to the same thing.
then we will have to go for the limb lengths also and also those things.
But I think, incorporating the shoulder and the iliac crest would not, in a single study, would not be a nice idea. I mean, I would agree with Bhavuk focusing on shoulders, because that is a very important sort of a gray area which still exists in the deformity literature. It would be nice to actually look at many things, including correlation of radiological and clinical shoulder balance, the difference between the patient satisfaction, the medial and the lateral shoulder height differentiation, and all this. So I would encourage Bhavuk to stick to shoulder only.
But won't the limb length discrepancy be compensated for in a good X-ray, right? If you do a standardized X-ray, the limb length discrepancy has to be compensated for. So that should not be a confounding factor.
Absolutely.
Right? But even otherwise, I think the proximal curve may be responsible for the clinical shoulder balance, because the rotation in that may have an effect on the shoulder clinical outcome. So any other points before we move forward?
Oh, the flexibility is also taken into account. No? I didn't see the flexibility of the proximal and lumbar curves before and after. I think they are there in the criteria when you are actually going to measure the shoulders pre and post op.
I think that we will cover it in the Lenke classification itself. I think Dr. Sigurd has something to say.
Yeah, sure, Dr. Sigurd.
It's a very good study and an important topic again. Just a brief comment about left versus right. And because in the majority of the cases, we're concerned about shoulder elevation that's contralateral to the convexity of the main thoracic curve. But in some of these cases, if there is a left main thoracic, then the left versus right may get confused. When you have left assigned to negative and right assigned to positive, you may consider ipsilateral to the main thoracic convexity being positive and contralateral to the thoracic convexity being negative, so that the averages don't spoil the numbers.
Yeah, well taken point. Yeah.
Point well taken. So if that's it, we move forward with the next study.
There's also some point to say.
Yeah, sure.
Are we going to have uniformity with regards to the reduction or the correction maneuvers in these cases? One. And two, also we are obviously factoring in the functional outcomes with regards to SRS, yeah?
Pankaj, we did the first study, and in which we did all these things, the parameters, the SRS outcome. We are going to have the SRS outcome in this thing, in this study also. But the point here is that's why we are doing the multicentric studies, because how the things unfold at multiple centers and what are the things they matter, they actually determine the shoulder height. So we are going to look at this thing. We cannot standardize the surgical techniques across the whole centers, but that is the importance of the multicentric study, I think.
But if we also have the technique as one point of consideration onto what is the outcome, I think that will also make an interesting component of it, right, Babu?
Yes, sir.
Sure. Thanks, Pankaj. So we move forward. The next study is from Ganga Hospital, a novel classification system for spinal instability and assessing surgical candidacy for patients with active spinal tuberculosis, an evidence-based approach and multinational expert consensus study. Dr. Dilip Chand Raja will be presenting this study.
Sensors novel instability scoring system in spinal tuberculosis. Spinal tuberculosis is the most disabling form of skeletal TB, leading to paraplegia and deformity. Despite the fact that multi-drug therapy has converted STB into a medical disease, two critical scenarios where surgical intervention is required include instability and neurological deficit. The evaluation and assessment of neurological deficit is very objective and precise, but the ability to identify and estimate instability is very subjective and is generally based on individual experience. Judgmental errors in instability assessment can lead to progressive deformity and can also perpetuate neurological weakness. On the other hand, unnecessary surgical intervention in stable lesions leads to waste of resources, unnecessary morbidity, mortality, excessive blood loss, increased hospital stay, and even possible iatrogenic neurological deficits. With around 15 lakh patients getting affected by spinal tuberculosis in the world annually, there is an urgent need of the hour to develop an objective assessment of instability. The challenges being influence of multiple clinical, radiological and biological factors, which again vary across different pathological conditions such as trauma, osteoporosis, metastasis and infections. We employed a very systematic and logical method of development for scoring system, and where all the steps were statistically approved. In the phase 1, a 10-member expert panel comprising experienced spine surgeons of 25 years from different geographic locations performed an independent review of literature to enlist all clinical and radiological factors contributing to instability and surgical candidacy, followed by a development of questionnaire which was then circulated in an online survey tool, SurveyMonkey. International consensus study of 68 spine surgeons from 12 different nations were performed. This is the histogram which shows an overall opinion on various factors contributing to instability. And the factors which were considered contributory by more than 70% of the participants were reviewed and a consensus achieved. We segregated the factors into those which contribute to actual mechanical instability and those which determine surgical candidacy. An open-ended questionnaire in the survey tool included the top 5 factors which contributed to mechanical instability, which revealed spine at rest sign, deformity angle, vertebral body loss, and junctional involvement, and young age at presentation as the top 5 factors. Coming to young age at presentation, we all know that it is biomechanically a pediatric spine is very unstable, which could lead to buckling collapse because of high load or destruction as in spinal tuberculosis. And the consensus study also revealed the same. We put age less than or equal to 15 years, a score of 1. Regarding junctional involvement, the consensus study revealed that lumbosacral junction was stable, whereas cervicothoracic and thoracolumbar junctions were considered unstable because of the biomechanical transition from a mobile segment to a rigid segment, resulting in unusually high tensile forces. So either cervicothoracic or thoracolumbar junction was given a score of 1. Regarding severity of deformity, most of them agreed that a deformity of 30 degrees was considered unstable. In the calculation of deformity for lumbar vertebrae, we used adjusted deformity by adding to the kyphotic deformity the amount of lordosis lost, which was 8 degrees for the first 3 upper lumbar levels, 15 degrees for L4, L5, and 20 degrees for the L5, S1. We also noted that a 30-degree deformity or a 40-degree deformity contributed by single vertebrae is much more unstable than 40-degree contributed by 2 or 3 vertebrae. So in order to distinguish these two factors, we describe what is called the sagittal deformity angle ratio, which is deformity divided by the number of vertebrae. So the threshold was in a single level vertebral involvement, a deformity of greater than 30 degrees, whereas in multi-level involvement, a deformity angle ratio of greater than 15 degrees was considered unstable with a score of 2. Coming to vertebral body loss, it was calculated by as proposed by Professor Rajashekharan sir initially. And in case of multiple vertebral involvement, we calculated what is called as the TVBL segmental ratio, which is total vertebral body loss divided by the number of vertebrae contributing to the vertebral loss. So a score of greater than or equal to 0.5 was given a value of 2. Regarding posterior column failure, there was a clear distinct difference between posterior column involvement in spinal tuberculosis and posterior column failure. While posterior column involvement need not be necessarily unstable and amenable to medical therapy, the posterior column failure is an indication of anterior and middle column failure, therefore higher at risk for higher instability. Therefore, a score of 3 was given for posterior column failure. So this is a final novel scoring system with 5 main factors: age, cervicothoracic or thoracolumbar junction, deformity, total vertebral body loss, and spine at risk sign, amounting to a total score of 9. We then checked for the content validity across 60 representative TB cases. All the 5 factors were found to be statistically significant and associated with unstable, unlike the other factors such as lumbosacral junction. Regarding the threshold value for the scoring system, we use ROC analysis. We found that a score of 0 or 1 was stable. So score of 2 was potentially unstable and 3 or above was definitely unstable. Having developed the scoring system, we just wanted to validate in a new set of 30 spinal TB cases. The accuracy was tested, and also among 10 spine fellows and orthopedic residents, we checked for the inter-rater reliability and intra-observer variability, which all showed excellent results for the scoring system. Now moving on to the proposal for multi-center validation, though the reliability and reproducibility among surgeons who developed it is excellent, we have to validate in a multiple center prospective analysis. An independent evaluation should be done. We propose that it could be done in 6 centers in a prospective way. Each center will contribute 10 cases of spinal tuberculosis treated at the center with the equal number of stable and unstable lesions. So a total of 60 representative cases with X-ray, MRI and CT will be blinded and circulated using an online survey tool among 5 surgeons from each of the 6 centers. So there will be 30 spine surgeons opining on 60 cases from 6 different centers independently in grading sessions 1 month apart. The results will be analyzed for inter-rater reliability and accuracy, percentage correlation and other correlation parameters such as kappa coefficient, Kendall coefficient and intraclase correlation will also be analyzed. More importantly, the internal consistency among the evaluators will also compared using Cronbach's alpha correlation and correlation matrices. Thank you.
Open for discussion.
Yes. Good morning, sir. Am I audible?
Yeah, sure. Sir, your expert comments. Dr. Rajashekharan, sir, would you want to
The thing is that we went through the same format in which SynScore and others have been formulated. So we got the opinion from 68 surgeons from 12 different countries. They went through all the 30 cases and also gave their opinion. So it went through a very rigid and good, robust process, but it needs validation from multi-center. So I think any of the 6 centers or even more, we don't mind, but at least 6 centers. So if we get more, the power study says 30 surgeons have to validate, it will be pretty good. So if we have more centers, if we have 10 centers, then it can be 3 surgeons from each center, the 3 senior surgeons, or maybe we can take the senior surgeon and second year spine trainee so that we will have everything. I think Sig wants to say something. Sig?
Yes, Roger, thank you for the opportunity. Again, a very important topic to be able to predict stability to guide care. I was one of the authors of the SINS classification as well as validation, and I recognize the similarity in the study design. And I think you've included some variables that are much more specific for tuberculosis. I think it may be interesting to actually, in parallel, look at a SIN score and see which variables are unique to tuberculosis. And then finally, what will be interesting is to actually look prospectively at how well this may predict progressive deformity.
Yeah, so Sid, that's an excellent point, but you would see that the spinal signs, junctional involvement, the way we calculate the deformity angle ratio, all these are very, very specific to spinal tuberculosis. And they have all been validated to be good. And we were quite happy and surprised that in the 68 surgeons, their opinion was very homogeneous, not too much, people all felt the same. Because when we treat tuberculosis, we frequently find people have missed the bus. The surgery has not been done at the right time, and they come to us with healed, huge deformities where they are completely different, like North Pole and South Pole. Treating a fixed, healed, severe deformity is so much different from treating it when it is very active and when it is very flexible.
Any other points from any of the panelists?
There was a discussion when we are discussing this in the committee. So these changes are dynamic in the sense of somebody treating these patients conservatively. Over a period of time, the stable can change into unstable. So will that be addressed here in a different point, or once we are sure that this patient is non-surgical, then only we'll move into this point?
Naresh, repeat it again.
So this
what did you say?
So the stability is a dynamic change, in the sense like some one patient is being treated conservatively. Over a period of time, he may change from stable to unstable. So at which point in time do we need to take this score?
The point of time which the surgeon meets the patient and where he is making the decision. So it is it's a long time cycle. We know that it can become unstable, but it is the point of time which the surgeon. So if you are doubtful about a patient whether it is unstable and you put them on conservative therapy, but after 2 months when you see them for a review, there is a change in the radiology and a change in the system, and then the score becomes more, then you know that's the time that you have to revise your decision on conservative and go on to an operative treatment. So this score can be used multiply over the period of follow-up on the patient.
So that's what we had discussed. One important point would be to document the stage at which the score is taken, and would we want to take the score at multiple time points for the same patient? That was the question that we had discussed.
So Chandra, that will be interesting because I had not actually thought about it. So we can actually score these patients over a period of time and see which patients are actually deteriorating.
Right.
Whether there is a possibility to predict from a retrospective review of these patients on which are the patients who are deteriorating.
Right.
Yes, sir. I think it has to go through registry. Shall we really make it mandatory?
All multicentric studies now will be through the registry only.
Yeah, sir. I would be.
We have to give consideration, like some centers like AIIMS do not allow to participate in the registry. So we have to take that into consideration. Otherwise, where centers allow, it has to be through the registry. Any other point? There was another question, sir. Is there any special consideration for junctional areas? Charanjit has asked that.
Yes, sir. We have given a score for involvement of cervical, thoracic and thoracolumbar junction, but not lumbosacral junction because it is generally considered stable, as well as in the expert opinion consensus, it was found to be stable. So a score of 1 has been given to cervicothoracic and or thoracolumbar junction.
Fine. So Charanjit, I hope that answers your question. Any last questions before we move forward? Fine. Thanks, Dr. Rajashekharan sir and Dilip Chand Raja for this study. The next study, multicentric study, is a prospective study to be conducted comparing the outcomes of discectomy using various MIS techniques. Arvind Kulkarni will present this study.
The prospective study is still on. This is the second part of the retrospective. Dear seniors, colleagues and friends, it's a matter of pride and privilege to make this presentation. I would like to pay my gratitude to all the participating ASSI centers, Dr. Preetham Rajamani and Dr. Praveen Goparaju, my fellows, and Mr. Akshay Patil, our statistician. Now, various techniques of performing lumbar discectomy are prevalent, the goal of each technique being relief of patient's symptoms. There is a claim of one technique being better than the other, but the evidence is low. There is no single study that has compared all the techniques. ASSI, being a rich mix of surgeons cultivating various techniques, forms a very perfect ground to perform such a study. So this particular study has a retrospective and a prospective wing. Now, the part 1 of this retrospective wing was presented in last year's virtual ASSICON, where we compared the complications of various techniques of discectomy. Now today, I'm presenting you part 2 of this study, wherein we have compared the ODI, VAS, operative time, blood loss, hospital stay, and incision sizes of various techniques. So it was a retrospective study, and consecutive patients that underwent discectomy using all these various techniques. The data was collected. The premise was to have a minimum follow-up of 2 years, and July 2019 was the point in time when we started collecting data. So these are the inclusion and exclusion criteria. I thank the participating centers for contributing and sharing their data to the study. So these were the statistical studies that were performed, and p-value less than 0.05 was considered as statistically significant. So the sample size was 810. This was the male-female ratio. The mean age was 44. The average BMI was 26. The average height was 5.2, and the average weight was 70 kilos. So coming to results, all techniques performed similarly with regards to ODI score. There was improvement in ODI in the first 6 months, and that sustained over a period of next 1.5 years. Same with regards to back pain, wherein the minimal access groups performed slightly better than the more invasive approaches. And VAS leg pain decreased similarly. All the lines ran parallel and had a similar sustenance over the next 1.5 years. The operative time was highest in open discectomy group and lowest in the transforaminal group. Blood loss was highest in the microdiscectomy group and lowest in the interlaminar group. The hospital stay was highest in the open discectomy group and lowest in the transforaminal and interlaminar groups. The incision was highest in the open discectomy group and again less in the transforaminal and interlaminar groups. So coming to discussion and conclusion, in the literature you can see various techniques compared, but it's usually limited to 2 or 3 techniques only. So this stands out to be the first multicentric international or national study to compare various prevalent techniques of performing discectomy. This is an extremely large study with 810 patients involving many centers. When you talk of ODI and VAS, there is no much difference between various groups. There are no significant difference between various groups. Though there are minor variations here and there. But in terms of other parameters, there are differences. For example, with regards to operative time, the highest operative time is with open discectomy, followed by micro, followed by tubular, followed by interlaminar, followed by destendo, followed by transforaminal. When you talk of blood loss, it is microdiscectomy, followed by open discectomy, followed by tubular, followed by destendo, followed by transforaminal, followed by interlaminar. When you talk of hospital stay, it is open discectomy, followed by destendo, followed by microdiscectomy, followed by tubular, followed by transforaminal, followed by interlaminar. And in terms of the incision size, it is again led by open discectomy and ends at transforaminal and interlaminar being equal in terms of the size of the incision. Thank you. I'll be happy to take any questions. Thank you.
So any comments, suggestions, questions? So everybody is happy. Is it on expected lines? Arvind, what was your hypothesis?
Hypothesis was similar, sir, and kind of fits the bill. Because there are obvious differences when it talk in terms of hospital stay, incision size, the invasiveness. But overall, most of the patients get satisfied. That's why the open discectomy group still continues to do open discectomy. And the people who do micro discectomy, they're happy with their results. So they still continue to do the same. It's just the minor differences which are probably, cosmetically appealing to the patient that can drive patient towards a particular surgeon.
No, in the inclusion criteria, is it only a paracentral disc or could it be also central with paramedian discs?
Yeah, it could be central. We have data on that also. It's too much in detail, sir.
The only thing is, I don't know how it is with the others, but at our center, for my cases, we would do them minimally invasive, but if there is a central with significant paracentral on both sides, we want to have a look at the nerve root on the other side, because sometimes when you do the discectomy from one side, the patient wakes up with leg pain on the other side. So we want to have a look to be sure, and then we go in for an open discectomy rather than a endoscopic discectomy. What are your observations?
This was including patients with unilateral leg pains.
Yeah, unilateral leg pain. But if there is a significant paracentral disc bulge the other side, because as you touch the annulus, sometimes we have had patients who woke up with leg pain on the other side. Did you have a similar experience?
Not had such experience with the TLIF procedure. When you ignored the opposite side, and done TLIF on one side, but not with discectomy.
Dr. Rajashekharan wanted to say something.
Yeah, I was just going to ask the same thing. So if we are going to look at the outcomes of procedure for a disc, then a lot more of the factors which we know affects the outcome needs to be decided. I mean, the age, the disc height, foramen, and multi-level problems and size of the disc, location of the disc, and everything. So if we ignore all those factors, then it will be difficult. I would actually suggest that we should take the age plus the type of the disc has to be, we have to make sure that there is no change in that. Third is, I think, if you look at the poor results of discectomy, 100 cases from our unit, it is never a problem of whether, because we now are doing endoscopic, we are doing microscopy and everything. It is never a problem of what did we use. I mean, it is always a problem of whether some disc was left behind, and is there an infection, is there a discitis, or whether there is a dural tear or something. So in the largeness of things, I think whether you use an endoscope or a microscope, it is the least important factor, I think. So that's my opinion. So
last time we compared the complications of all these various techniques, the same centers, and the conclusion was almost in similar lines.
Yeah. I would think that in a well-performed procedure, you will come to the conclusion of the same thing. Microscope or endoscopy, everything is the same. But I think it's okay, we can do it. But the result, again, is probably known already before the study started. That's what I think.
Any other comment, suggestions? So, Arvind, this is the retrospective arm of the prospective study which you are already doing, right?
No, we had two studies, retrospective and prospective. The prospective is still collecting data. Because of this COVID issues, there are very few cases collected.
Right. So any other, Swamijit wanted to say something?
So further data collection would be on what lines? What exactly would be your hypothesis? The COVID situation is getting better. You would be getting more and more patients. So what is the end point of this prospective data collection? What exactly do you want to look at? Because as I'm completely in agreement with Dr. Rajashekharan that there are too many variables which are associated with the results, the outcome of a discectomy surgery. So possibly the type of discectomy is the least important of the variables.
If we one of the variables we deleted was the learning curve. So these are surgeons who already, start at least minimum of 5 years in practice. They already are. So
Arvind, I wanted to say that the outcome of discectomy is based on too many variables, and the least important variable possibly is the approach, whether it's an open or a micro or a tubular. So what are your thoughts on that?
So that is nowhere proved. That's why there is always this debate of one being better than the other. So at least it lays down to rest this particular argument. This paper can be quoted when such an argument comes up.
Arvind, the suggestion is that we have to definitely go ahead with this. But if we can consider also other variables, which data you would have already collected, and see if there is any effect on the outcome with these multiple variables, that may add to the quality of the publication. Right?
If you have really collected data extensively, if you have really collected data extensively, the type of discectomy can be one of the variables. But you should really utilize that data for analyzing the other variables.
And the study was to check on the technique itself, not discectomy per se as a surgery. So that was the goal.
Fine. Any other suggestions?
Arvind, what have you done to the cauda equinus? Have you eliminated them or
those are not considered?
Not considered.
Any other questions? So Arvind, where do we propose to submit this for publication? Which journal?
So we have two papers now. One is on complications and one is on the outcomes. So, sir, I'll take your suggestion as to where to submit it. We are working on the...
So I think if we do that early from the review process also, we will get some inclination as to what variables, whether we are okay with the prospective study or we need to incorporate some other variables in that, right?
Yes. So this being the nature of the study being retrospective,
right.
There may be some lacunae here and there, but prospective will be more solid.
Right. So with that, compliment Arvind for the study and we move forward.
Sir, as a part of ASSI project, we also discussed, I don't have a PPT, the project on the checklist, which I just presented. So we have mailed it to about 15, 16 centers, big centers, busy centers. Most of them are here in the panel. I would request them to revert back.
Yeah. We decided that that would be one of the multicentric studies, right? So that's already a decision taken, right? So anybody has any, that could be discussed through circulation, Arvind? And any burning points here we could definitely take up. I will only say that I didn't get an opportunity to talk at that time. There was not time. There was not much time. But I think what Gautam pointed out only highlights the importance of counseling, right? The importance of counseling the patient and the importance of being able to counsel the managers to be able on the importance of this. I'm sure as a manager also, I have a dual role, so I understand the importance, but we should have the capabilities of being able to influence our managers. That ultimately it is in the best interest of the institution if we have a safety checklist like that. So that should not be a problem because there is enough evidence in that favor. I don't think that should be a problem in implementing what you have suggested. So I would totally support that. So go forward. Last multicentric study which is proposed is on management of thoracolumbar burst fractures, a multicentric study. The literature review was done as part of the ISCOS spine trauma study group, and Michael Fellings was a part of that. And we came out with areas where we don't have a clarity, and those formed the research questions for this study. So can we have the video, please? Thanks for giving me the opportunity to present the protocol on management of thoracolumbar burst fractures, a multicentric study. We know that thoracolumbar burst fractures occur because of compression failure of the anterior and middle columns under supraphysiological axial load. Being a transition zone between the rigid thoracic and a flexible lumbar spine, fractures are common in these regions, and they constitute around 17% of all major fractures. Over 30% are associated with neurological deficit, and if inadequately managed, long-term consequences of kyphotic deformity, late neurological deterioration, and chronic pain can hamper the quality of life. Management is based on three principles: biomechanical stability to promote healing in acceptable alignment, neurological optimization, and long-term preservation of maximum painless mobility. Numerous classification systems have been proposed, including TLIX and the latest AO classification. However, none of the classification systems have been validated. The presence of neurological deficit is generally considered an indication for surgical management. However, such patients can also be successfully managed with conservative treatment. The ISCO Spine Trauma Study Group did a literature review on conservative management of thoracolumbar fractures and documented the good outcomes of conservative management, and also compared the outcomes between conservative and surgical management. And the salient features of this review was that there are many controversies regarding management of these fractures. They are either being undertreated or more often overtreated. Criteria for instability have not been standardized. So the rationale of the present study was to give a clear answer for the gray areas in the management protocol of thoracolumbar fractures. And our research questions are, do the parameters of instability for other fractures like PLC involvement hold true for burst fractures as well? What is the role of bracing in pre and post-operative period? What is the optimal approach? What are the optimal levels of fixation? And is there a relevance of Gaines classification in the management of thoracolumbar fracture? The aim of the study was to try to assess the parameters of instability, role of bracing, and evaluate radiological and functional outcomes of conservative as well as surgical management of thoracolumbar burst fractures. The study objectives were to define the indications and protocol for conservative and surgical management of thoracolumbar burst fracture, to define the ideal construct for the fixation to gain the maximum functional outcome, and to assess the incidence of complications and strategies of prevention associated with both conservative and surgical management. Our study hypothesis is that mechanically unstable thoracolumbar burst fractures with neurological deficit should be managed surgically with a posterior short segment fixation, preferentially with screws into the fractured segments. Mechanically unstable burst fractures with an intact neurology could be managed either conservatively with a sequential follow-up or monitoring any increase in kyphosis, or surgically by a posterior short segment stabilization. In fractures with a load-sharing score of 7 or more, the surgeon may consider an additional anterior augmentation on individual merits. Indian Spinal Injury Center would be the coordinating center, and there would be other participating centers, MIOT Chennai with Dr. Charanjit Dhillon as co-PI, Kothari Medical Center and Park Clinic, Kolkata with Dr. Soumya Basu as co-PI, St. John's Hospital, Bangalore with Dr. Mallikarjun Swamy, Stavya Spine Hospital, Ahmedabad with Dr. Bharat Dave, and Ganga Hospital, Coimbatore with Dr. Raja Sekharan and Dr. Joy Shetty, and Gangaram Hospital, Delhi with Dr. Shankaracharya. These are the proposed centers, and they will be participating in the study. It will be a prospective, multicentric, comparative study. All patients with thoracolumbar burst fractures, AO, A3 and A4, with or without neurological deficit will be included. Age between 15 to 60 years, and those willing to participate in the research study will be included in the study. Of course, those with concomitant fractures or other conditions contributing to neurological deficit or pathological fractures will be excluded. It would be conducted over a time frame of 2 years. The statistical procedures would include mean plus minus standard deviation for continuous clinical and functional outcomes, count with percentages for categorical clinical and functional outcomes, chi-square test to find association between two categorical variables, t-test to compare a continuous outcome between the groups, and SPSS V25 will be used for analysis. Calculation was done to estimate sample size using NMaster software based on the number of centers, clinical and functional outcomes and references, and a sample size of 96 for each participating center was estimated considering on a 10% dropout rate. The study will start only after the approval from the Institutional Ethics Committee of all the centers. Outcome measures would be INSCI, SCIM, and ISCIS, And for the radiological outcome measures, X-ray, CT, and MRI would be the outcome measures. The time points would be at admission, discharge, and 6 monthly, except for X-ray, where it would be also done more frequently, and CT and MRI would be done only before. So the first step would be draft the protocol, then ethical committee clearance, data collection, data analysis, and manuscript writing would be there. So the references and the literature review of the spine trauma study group will come in handy. We will look forward to the participation of the centers and are happy to respond to any questions. Thank you. One of the questions that was discussed during our discussion earlier was we should try to keep the research questions to a minimum, but all these have been taken into consideration while trying to calculate the sample size. We looked into the number of cases at our center over a 2-year time frame, and we are very much comfortable in trying to collect these number of cases. But the same cases, the same data could be used to answer all these research questions. So happy to answer any questions and would welcome any suggestions or comments.
Chabra, I thought we decided in the meeting that the PLC injury would go off the list because it's B-type injury. I thought.
Because it is? Pardon?
B-type injury.
Yeah, so we can include B-type also.
Yeah.
Because that will complete, because that is one of the burning questions, right? That is the difference. And trying to, the thoracolumbar burst fractures, the stability criteria may be entirely different than the other types of fractures.
Would the time of presentation be one of the exclusion criteria? For example, a patient who comes to you 3 weeks or 4 weeks or 6 weeks after the injury.
That's a good point.
Can that be recruited, or would you restrict itself to the first 3 weeks of injury?
We will need to restrict it. We'll look at the literature, probably cases presenting within 10 days of the injury. But it has to be based on...
At least more than 2 to 3 weeks would jeopardize the patient recruitment criteria.
So any suggestion on to what would be, should 2 weeks be kept as a cutoff?
Yeah, 2 weeks. I think 2 weeks is fine.
Right.
Or maybe even 1 week.
1 week?
1 week may be a bit early, sir. We get
absolutely. Centers do not get those, so 2 weeks would be better.
So we keep it 2 weeks and try to study also whether the time of presentation makes any difference.
Okay. One other thing, Chabra, I was wondering that whether in your outcomes,
right, sir,
too many, whether we are asking too many questions because we are looking at parameters of instability, PLC involvement, role of bracing, pre and post-operative period, optimal approaches, optimal levels of fixation, relevance of gains classification. Are we trying to evaluate too many things? For example, if you're looking at gains classification, relevance, but then we have people who are treated by different methods, some conservatively, some with just posterior, some have been treated by anterior, and some with segmental fixation of the index segment, some without. So unless you're standardizing your treatment protocols also, at the end of it, when you come to analyze, it is going to make a big challenge in trying to get a homogeneous group for comparisons. It's going to be very, very difficult.
So, I take your point. The outcome measures will remain the same. At the end of the time, if we do not achieve statistical significance in any of them, we can exclude them. Means the thing is that the whole gains criteria was based on 36 odd cases only. So if we have even 200 cases which fulfill the criteria, I think it will add value to the literature. That was the whole effort behind it, sir. all these questions, when we were discussing in the spine trauma study group on a topic for discussion in the workshop, Michael said there is so little known about these burst fractures, and we can contribute to literature substantially if we do something about it. So when we did a literature review, everything came out. So we will the same outcome measures will be there, sir. If we do not get a statistical significance, we'll eliminate that.
I think we should do this study very well because it's very, very internationally relevant.
Right.
And I have a particular interest in this because the AO Spine is doing a multinational study at a huge cost of $375,000.
Right.
And if we are able to do a similar study very well with no cost, I just want to show AO Spine that they are so expensive in every single thing that they do. So I really wish that this study will come out very good. I am fighting against huge costs in AO Spine, and I really wish you success because then they should be compared with the way AO Spine drains money in its studies.
Right, sir.
However, just one clarification. This includes a conservative group also where, and then we have to do follow-up CTs of those groups and MRIs also.
See, the time points, X-ray would be there. CTs could be done at only 1 year, right?
Okay.
Follow-up CT at only 1 year. So it would not be at all the time point.
Yeah. And one more challenge for you will be, Chabra, that many of these people are coming to the hospital from different areas. For example, I'm sure you will train from Rajasthan, parts of Bihar, Himachal Pradesh, everything. Once these people become better after 6 months, to get them for your 1 year follow-up is a huge challenge.
The ISCIS can be done, that is a PRO. Means many of the outcome measures could be done just by patient interview as well, but radiological parameters will be an issue. We could ask them to get an X-ray done and send it to us, but I agree in India, in these studies, follow-up are an issue.
But with telemedicine, it has become easier, Dr. Rajasekhar. When I tell them that I will see you and I'll pay for your X-rays, they get it done actually.
Shankar, we are doing a similar study. Already it's on the way. For some 36 patients or something has been included. But to get the 6-month X-ray from all these people, actually we would have made at least 20 phone calls to each of these guys to get an X-ray and send, The minute you call them and ask for something, they think there is something fishy. Why is the hospital calling me and asking for an X-ray? What is this problem? That, this and all. It's the Indian thought process is the problem.
Yes, Abhijit?
The other thing is
it's a very interesting topic.
For a prospective multicentric trial like this, you should be very careful in asking all hospitals to have all the investigations done. For example, still there are many hospitals which will not do both a CT and an MRI other than an X-ray. So you must make sure that all the data is there. For example, all these patients will have to get a CT, an X-ray, and an MRI for all these patients, and a follow-up CT of at least 1 year.
We'll do this as part of this. We'll ensure that it is there in the spine registry. We'll allot it to fellows and ensure that all fellows at all the centers contribute to that. Any other points for discussion? I think Gautam tells us that we are running late, but I said since it was the last session, we could stretch it forward in the interest of having a good protocol before we make a move forward for the multicentric studies. The discussion was very interesting and helpful, and I'm sure we'll be able to incorporate all these changes in the protocols. Shankar, would you want to conclude the session?
No, I think just to reiterate that I think the discussions are good, but as I think Dr. Rajasekhar said, henceforth we will get all these protocols well weighed and assessed before we present them in the ASSICON. I think that is very important, that we go through all these parameters before it multiple times, get the things laid out, all the performance laid out as was done with the TB study. And then I think presenting it makes better and then takes advice. And that's the only thing I have to add.
Yeah, we had 2 sessions of discussions amongst all.
Yes, we did. I was part of those 2 sessions as well.
Yes, Swamiji.
So can I make a last point, sir? Yes. An appeal to the current president, the immediate past president, and of course, the president emeritus, is that we should have a proper official statistician of ASSI, because there would be so many research proposals coming in, and there would be many centers which would not have access to a proper statistician. So if you have an official statistician or a group of people which we can be in tie-up with, I think that would make matters much more easier, and many data which is actually not seeing the light of publication can come in with this statistical support from ASSI.
Yeah, I
agree. Till such time that you find an official statistician, I offer the services of our institutional statistician who has a vast experience in this.
So finding a proper statistician is not a problem. Finding the funding for him is a problem. So
that's why I wanted ASSI to come. Dr. Rajshekhar wants to say something.
You are the secretary. You are in charge of funding henceforth, Gautam. And
Gautam, give 10% of your stock market upcoming value, so that is fine. But anyway, on the true part of it, ASSI doesn't have a funding. We can put them on a retainer charge of about 3 lakhs a year or 4 lakhs a year, where they have to completely look at all the approved projects of ASSI. It will be really worth it.
Yes, sir.
Can I share?
So if you agree, then the current president shall put this up on the agenda, and within the next few weeks or months, we should finalize somebody who is on a payroll of 3 lakhs a year.
3 lakhs a year? बहुत ज़्यादा हो गया.
We'll negotiate that.
We'll come up with what is a true value. What sir is trying to say is even 4 lakhs a year is worth it. So we will. He's not quantifying what amount you pay. Yeah, Bharat.
Yeah, we at Stavia have enrolled one statistician and who charges around 3,000 rupees per study, and he is ready available, and that is not a big sum for a study of whatever career we are planning to do. 3,000 per a month, and he is ready to analyze our data and give the guideline from the day one. To have somebody who is in the center, it may not be possible because somebody will be pushing, pulling this, that, and he may not reply. So I think local statistician 3,000 rupees per study is not a big sum.
So
Bharat, what I wanted to make sure is that your hospital might have a statistician, Dr. Chabra's hospital might have a statistician, but out of the growing number of youngsters who are really wanting to do studies, if they have an ASSI support of a proper statistical office, I think the inhibitions of publishing data would come down, and we will see a lot more publications seeing the light of the day.
So may I make a point there that we will, between the research committee, the secretary and the president, we will finalize someone on study basis, and ASSI will be happy to fund the costs of statistician for all such studies which are approved.
Yeah.
Right?
ASSI studies.
Yeah, all the ASSI studies.
All the ASSI studies.
Thank you very much, Dr. Chabra and Dr. Shankaracharya, for moderating this session. Fantastic stuff has come out of it. I hope it takes the ASSI research further, and we will be able to come out with something very positive out of these 6 studies in the time to come. And I thank all the speakers and all the seniors who have been here to guide this whole session through. And we look forward to seeing all of you at 2 p.m. in the afternoon again, when the afternoon session begins, and at 6:30 p.m. in the evening, when we have a social program, when Dr. Basu is going to dance with us from Kolkata. And thank you very much. And I would like to thank the MCs of the hall, Dr. Ayush, Dr. Pankaj Kandwal, Dr. Ankur and Neeraj, who have put in stupendous efforts to put this through. Thank you very much.